Samantalam yalit walang yulad walang yakul lahu kufuwan ahad. The name of Allah. My name is Professor Kamran Khalid Fajar. I am Professor of Surgery and Dean and Chairperson Department of Surgery, Patna Medical University, Lahore. And I would be basically participating in this session as one of the representative of Patna Medical University and the moderator for this particular session. It's my proud privilege to welcome the honorable guests from abroad as well as from various regions of the Pakistan, and I'm thankful to all of them to be here for this very, very important topic which we basically chose for this country. And as you must have realized that this is one of the important need of the art these days. Our participating guests for this session would be the chair, Dr. Varda Shafi. I welcome Dr. Varda. She is joining us from the United Kingdom and has a vast experience of GPship as well as the occupational health. Myself, I have introduced you about the guest here for this session would be Professor Dr. Munida Qayyum. Now we have a student here with us. Our coordinator for this particular session is Dr. Afsar Najeeb. We have Dr. Ashraf Nizami as one of the very hot, well-known participants. When he would come, he would all of us know about him. छोटे से बचपन से हम अपना जब प्रोफेशन में दाखिल हुए हम सर का नाम सुनते आ रहे हैं और सर को देखते आ रहे हैं. We are proud and we are privileged to have him here as well. Sir, thank you very much. We have Dr. Zainab Hafiz. I was just talking to her. She is again renowned general practitioner from the United Kingdom, but these days for the last 1 year she is basically doing a great job for Pakistan. She settled in Islamabad and she is involved and engaged in the teaching and training of general practitioners there at federal level. We have Dr. Tariq Gohar sitting with us. Dr. Tariq Gohar is again one of the, I would say that जिसे आप उर्दू में कहते हैं ना हमागीर शख्सियत. I was just talking to him and he said that he remained here running the BHUs and general practitioners in Pakistan for quite a long time. He went to UK, he joined there the surgical training. He almost completed the surgical training and suddenly he realized that this is not for him and he went to the general practitionership. And nowadays he is one of the renowned general practitioners there in UK. Such a galaxy here with the experience of the general practices, the experience of the professional specialist practices, and with the experience of the occupational health services and the family health services, that I am sure that we are going to have a very exciting session today. Now, in the end, it remains my proud privilege to thank and then to welcome Professor Noreen Akmal. She is with us. She is a principal of Patna Medical College, Lahore, which is a constituent college of this university, Patna Medical University. She is director of the Department of Medical Education of Patna Medical University, and she is one of the renowned professor of gynecology here, and she is heading one of the units of gynecology here as well, Patna Medical University at Ganganam Hospital. Ma'am, thank you very much. Thank you. So, this session, but we were basically so that is why he was selected as coordinator for this session. The student chair, Horatul Ann, is around, and she would be representing the student body as well as the regarding the session of especially in the last session, the debate in the BHU's privatization. Now let us have a brief review of what we are going to have is the and why do we need it. Now this is the problem. This is the problem and the big question here. We start and we have just a introduction. Now that means if you have a look on this session, this is occupational health and general practice and general practitioner. So what are we talking about here? This is the question now coming to the mind of various people, especially in the developing countries, especially in Pakistan. And you can see that what is the problem here. We have various occupational hazards, we have various occupational risks, we have various occupational accidents. And then when these happen, you have the protest and demos of those who are the sufferers of these particular conditions. And they would basically be demanding that their rights should be protected, they should have safety, they should have occupational health advice and all those things. And this question keeps on repeating in this particular setup.
Rescue workers battled through the night to try and contain the blaze and save lives. But dozens died, many others were injured, some jumping from the burning 5-story building.
I was watching the stranded people. The fire was raging. People were jumping from the top floor.
Medical workers rushed the injured to nearby hospitals, but for many, it was too late.
Some bodies are completely charred and cannot be recognized. It is only possible through DNA tests. It was a big garment factory where lots of people were working. That's why it is difficult to assess how many have come out safely and how many were trapped.
Very unfortunate. One of the most unfortunate incidents which happened in 2012, the Baldiga factory incidents, and cost around 300 people, which are basically numbered. We do not know what is the actual number. We also do not know what happened to those who luckily survived and how are they basically experiencing their life as far as their psychological trauma is concerned with these incidents, as well as their families and all those things are concerned. So that brings us to the point that why do these happen, and then also to the point that the role of the general practitioner as well as the occupational health services, why are these necessary and why is this the need of the hour at this moment for this particular country as well. So if you have a look on the challenges in this country, that there is no independent legislation on the occupational safety and health issues in Pakistan. It's the biggest problem. And the was chapter 3 of the Factories Act and this and that exist. They cannot be enforced religiously by all these things because of various reasons we know in this country. Accidents are happening at the workplaces, not really reported. Accidents and deaths due to absence of the laws are not disclosed in order to put up the reputation of certain workplaces. They're so reputed that when the accidents happen, they would not like to report just because they would be highlighted. They would censor all the things and all those things. This is all about the occupation and the occupational health and the occupational hazards we are talking about. There is no supporting infrastructure and legislation report related to the occupational safety and health in this particular region. Majority of the workforce in the country is illiterate, over and above that, and is less educated. Labor force includes children and women who are completely unaware of the issues linked with the occupational health and safety, and there is no proper training or anything which let them know. And why children are included in this particular labor force? Unsupervised zones such as agriculture, construction, mining work usually hire illiterate labor force like these. They do not know their rights, they do not know, and the accidents happen there. Violations of the labor laws, disregard of the existing disregard of the occupational and safety protocols, non-registration of industrial units, all these things are basically. And finally, I would like to have in the end, for which we are holding this particular debate today, that there is no curriculum, there is no formal education till now in the occupational health, and there is no specialization in the rest of my knowledge in the occupational health here in this country. But that keeps on confusing us: who is a general practitioner, who is a family physician, where does this occupational health specialist exist, and what who is he? So, for Pakistan, in Pakistan, a general practitioner typically starts practice after medical work and does not have a formal post-graduate training in the GP in Pakistan. But in the developed world, they have their own programs and they keep on following the general practice services by obtaining their specialized degrees or diplomas in this particular field. Here, Professor Ashwin Nizami, when he would come, he would basically enlighten us that the general practitioners here, they keep on trying to go for professional development by holding various courses, workshops and all those things, levels, federal levels and provincial levels. We have public health institutes which keep on providing them the support and give them the minor degrees and diplomas and all those things. But then are they recognized by any accrediting body? Still, it is something which is to be debated. A family physician with a postgraduate degree or a diploma in the family medicine. Who is an occupational health physician? A specialist with a diploma or degree in occupational medicine by a degree awarding institute, having in-depth training and experience in occupational health services. So this is about, and these are various institutes and various degrees I have just reflected that they have the family of occupational medicine of the Royal College of Physicians of London. So all these students, look at that 1916 when the American college started all these things, and they are all now, since 1916 to 2016 and 2022 now, and we are still thinking and debating. Should it happen or should it be the need of the hour? This is the need of the hour, otherwise those accidents would keep on coming and recurring. Remember about these things. So this is just an occupational health. This is very important. It's not just, it's an area of work in the public health to promote and maintain the highest degree of physical, mental and social well-being of workers in all the occupations. All the occupations, regardless of whatsoever. And this is the objective. And this is a framework put forward by one of the leading institutes abroad in the United Kingdom, defining the occupational health hazards, occupational health services, and this pyramid of health care where the place of the family physicians and general practitioners proceeding towards the specialist and proceeding towards the subspecialties, the higher trainings in that. The patients are referred to them, and the patients are referred back again to the one, the family physician and the general practitioner for follow-up and for all those things. So that is how the pyramid works in the developed world. Somewhere here lies the occupational health physician, between that and there, and he has a very close liaison between the family physician and the general practitioners in this healthcare system. Now this is a paper, if you see this, the trend of occupational accidents and their underreporting estimation in the factories of Pakistan 1993 till 2003. It's a very famous paper published in one of the journals, and they reported this. Look at the black line, which is the non-reporting factories. Look at the grey line, the reporting factories, and look at the working factories, which are basically working here. This report is from 1993 to 2008, and if you look at the recent the statistics which are very hardly to basically obtain. The black line is even has become more steeper upward. This is their reportable incident and the fatal accidents they have reported. And you can see in the end 2008, if we follow this particular track, you can see that from 1993 to 2008, they have increased from 157, then 79, and then 679 fatal accidents. These are the ones which have been reported. We do not know what is happening. This is just the tip of the iceberg. Remember about this particular aspect. Okay, now this is one of the papers, very important paper, which has basically the coming 40 participants would be reflecting more on this. This is a consensus statement for the general practitioners and the occupational health services. And let us go for this. At present, occupational health professionals are too few in number to adopt the role of case manager or certifier of ill health and disability. So the general practitioner has a great role in all wherever the developed or the underdeveloped world. They are the great force and they are a great helping hand for us basically, because they keep on filtering the acute and chronic communicable, non-communicable diseases from us and let only those who really require specialized care to the public and the private sector hospitals to the specialists. A very important arm of our health service is the general practitioner here, but what we are missing is the occupational health services, appropriate occupational health services in Pakistan. Okay, I will quickly move on to the general practitioners. The same paper, the consensus statement, have an important role in exercising enormous influence during the treatment and recovery of their patients. But their role in assessing fitness for work, and that is where the occupational health services and occupational health specialists come into the picture. That for the working environment, for the factories, for the occupations, we need to have the specialists who basically assess all these questions regarding their fitness for that work, regarding their limitations and all those things. So the same consensus statement paper highlights this thing. Now they are comparing here the general practitioner and the occupational health. There I have highlighted this area and there it is enlarged. Who do not have continuing responsibilities for family care may be better placed to adopt an objective and proactive approach to vocational rehabilitation. The same paper continues that health professionals have a better knowledge of the workplace. These are the occupational health professionals. They have a better knowledge of the workplace. They are also motivated and ethically bound to help their patients. And that is the consensus, the actual consensus statement from David Bement. जहाँ से वो वाला पेपर निकाला गया था वो that was basically published there, and they say that general practitioners play a crucial role in this because they see many patients with chronic illness and disability, coordinate and provide effective clinical management, and they provide notes. For occupational health professionals, the core part of their role is assessment of functional ability. Okay. Let us come to the occupational health and general practitioners here. Again, there is a good paper, career focused in the British Medical Journal, published by those, the coming participants would be highlighting more about this. But look at this, many GPs now study for the Faculty of Occupational Medicine diploma. This is a recent paper, Occupational Health Leading the Challenge of the Next 20 Years. And we have given the model, how should it proceed. And that is the WHO current recommendation about the occupational health, the model formed by the WHO, and it proceeds like this: stage 1, stage 2, stage 3, and stage 4, a comprehensive services in occupational general practice and occupational health services. Do we have any law? Do we have any? So there is a National Occupational Health and Safety Act 2018 in Pakistan. Is it enforced? This is again something to be debated. It has defined everything. It has defined the act, what is it about. It has defined the occupational diseases, the occupational safety, the occupational health. Each and everything is defined in the act. The only thing is, it has defined the serious injuries or illnesses during the phase during the occupation. It has also has the definition of who is the worker, what is the workplace. I'm just giving you snapshots of this act. Now it has, look at this particular area. It has an establishment of a national occupational health service here in Pakistan. And look at who is the chairperson, the Prime Minister or a person nominated by the Prime Minister. I was just looking at the members and all those things. So there are ministries involved, there are chief ministers involved because they are the provincial bodies. Then there are the Prime Minister of the AJK, the Chief Minister of Gilgit and Baltistan. I could hardly find here except this, the Surgeon General. I could hardly find. So this is the Act 2018 that I am sharing.
Surgeon General means General Secretary.
Sir, मैं सर आपके लिए स्टेज सेट कर रहा हूँ सर, बाकी तो आप लोगों ने आगे करना है. Just setting the stage for the people. I am just advising you that this is the 2018 Act. अभी भी लागू है ये over supersede किया है. And look at the members here and try to find out, figure out a doctor, an occupational health specialist, a general practitioner. So this is about the information. Okay. What are the duties? Employer and employee both. Again in the Act. And what are the penalties? So there are penalties defined, which basically from various money as well as to the imprisonment, at least 2 years or more, and then confiscation of the factories, equipment, vehicle, all those penalties. But my problem remains: is this act really enforced in letters and separates? Is anybody looking after that this is being really followed, and all these things being done religiously or not? Yet to long way. So this is all about that. This is the act of 20 pages with the Supreme Court decisions, group from 3 countries, and all those involved in this act. So remember about this thing. So what is the way forward? The way forward is that we have the acts, we have all those things, but this is we who have to look into all those things. Strict monitoring and enforcement of national health, occupational and legislation policies, if there are any. Designing and development of curriculum. Now this is the thing which I basically wanted to stress more, that it should be part of our curriculum in the medical education, in the schools, starting from the schools to the colleges, to the universities, to at all the levels, the occupational health. थोड़ा सा community medicine में थोड़ा सा पढ़ाने की कोशिश करते हैं, और तो मुझे कोई याद नहीं मैंने कोई occupational health के बारे में अपनी किसी किताब में पढ़ा होती है MBBS के दौरान. I would like to have opinion from you, but and again I do not recall any of the book during my undergraduate, during my schooling or the college जहाँ पे कोई occupational health का कहीं पे भी कोई जिक्र हो या कोई उसके बारे में बताया गया. So not only this, but consultation with academia, degree diploma program in occupational health safety, capacity building of institutions and organizations, linking of training institutes with industries, awareness of campaigns. Now this is again the fourth pillar, but we talk about. So the first pillar remains, all the pillars on which the country basically moves. One of the pillars remains the media, and a very, very strong role of print, electronic and social media as far as the awareness for these particular hazards and all these things are concerned. Once we achieve the upper ones, only then this can happen. And then there is a close collaboration between the general practitioner, the family physician, and the occupational health physician. I thank you very much for your patient listening. And as I was telling that this is just a stage set for the upcoming participants, and you will be enlightened more by them now. So I would now like to invite Dr. Varda and to build upon.
And I work as an occupational health physician in UK. टॉपिक नया है और मेरा यहाँ पे जो डिस्कशन का टॉपिक है वो है occupational medicine and unmet need in Pakistan. So I think I'm very grateful to Prof. Kamran. He has given a very, I would say, extensive आप लोगों को उन्होंने बताया कि इंडस्ट्री में और बाहर हम occupational medicine को कैसे प्रैक्टिस करते हैं. मैं कोशिश करूंगी कि थोड़ा सा आपको बताऊं कि हम अपने ही सेक्टर में जो हमारा हेल्थ केयर सेक्टर है हम इसमें क्या करते हैं. ठीक है? तो सबसे पहले थोड़ा सा बोरिंग है और वो है इसकी डेफिनेशन, वो प्रोफ कामरान भी बता चुके हैं और मैं आई एम गोइंग टू रीड इट आउट बिकॉज मुझे कभी ये चीज़ याद नहीं होती. सो इट्स अ ब्रांच ऑफ क्लिनिकल मेडिसिन that focuses on the identification and management of health risks that employees may face in the workplace. It's a very interesting branch of medicine because isme you are dealing with the clinical as well as part of it is law, जिसमें आपका health and safety law आता है और आपका employment law आता है. Right. Now, occupational medicine को हम for the sake of discussion today, हम briefly divide करते हैं into two parts. Let's say one is the healthcare sector and the other one is the non-healthcare sector. Non-healthcare sector, yeah. So non-healthcare sector, as I said, kindly Prof. Kamran has discussed. और इसमें what we see is people from the industry, any employee who is employed anywhere. It could be industry, it could be aviation, it could be building and construction, anybody working in the supermarket, आपके जो labor class है, anybody who is employed is covered under the occupational health. ठीक है? और उनको हमने we have to help and support them staying safe at work. So that is basically occupational medicine, which is outside the healthcare sector. मेरा अपना ख्याल ये है कि हम यहाँ पे आज ज़्यादा लोग बैठे हुए हैं फॉर दी जो हमारी हेल्थ सेक्टर है. सो लेट्स सी व्हाट दी हेल्थ केयर सेक्टर इज. नाउ हेल्थ केयर सेक्टर को मैंने फर्दर डिवाइड किया है इनटू टू एंड दैट इज वंस यू स्टार्ट योर जॉब तो आप लोग आ जाते हैं इनटू द प्री एम्प्लॉयमेंट सेक्टर. ठीक है? प्री एम्प्लॉयमेंट में हम क्या करते हैं? सो प्री एम्प्लॉयमेंट में एनीबडी who is applying for a job in the healthcare sector has to go a battery of tests for health and disability assessments. Why do we do that? क्या ज़रूरत है? We can just say anybody who has graduated, they are fine. They just start to work as doctors and that's fine. The important thing over here is कि जो healthcare sector है, वो हम सब का it's a safety critical role. Why do I say it's a safety critical role? You people are dealing with human lives. आप patients को देखते हैं. So you have to be fit yourself before you can see somebody and you can assess कि आपने अगले patient को treat कैसे करना. So patient safety is number one, जिसकी वजह से we are going to get all the tests done. Then it is safety of you yourself. हमें पता ही नहीं कि आप say if somebody has mental health illness in the past, आप उसको when they will enter into the professional life, how are they going to work? क्या वो एक उस बच्चे की तरह या एक नए उस डॉक्टर की तरह काम कर सकते हैं who has got no underlying disability? या उनको कोई हमें adjustments provide करनी पड़ेंगी या उनके काम में कोई alteration provide करनी पड़ेगी so that they can easily they can sail through their careers. So that is another thing. Now ये इन चीज़ों के अलावा हमारे लिए जो बहुत important challenge होता है वो ये होता है कि हमने एक safe environment provide करना है to the medical community. Let's call that. So ये तो हुआ हमारा pre-employment. Now pre-employment में हम करते हैं क्या? More importantly we do the immunization history लेते हैं, आपके IMS and vaccination history है. उसके अलावा जो एक और बड़ी इम्पॉर्टेंट चीज़ है वो है आपके स्क्रीनिंग फॉर द ब्लड बॉर्न वायरसेस. आई थिंक आप सब लोगों को इसका अंदाज़ा होगा पाकिस्तान में भी हेपेटाइटिस की जो है दैट इज़ क्वाइट ऑन द राइज के आप लोग आई थिंक इट्स प्रीटी न्यू बट हेपेटाइटिस के लिए और फिर ये है कि इट कैन बी ट्रांसफर्ड टू द पेशेंट्स एज वेल. I've said that we screen them and we check them for the suitability in the exposure-prone procedures. Now, exposure-prone procedures वो हैं anywhere जहाँ आपके हाथ जो हैं they are inside the cavity of a patient and you cannot see them. उसमें ये है कि आपको कोई इंजरी हो जाए या पेशेंट से आपको इंजरी हो जाए you will not be able to see it. So उसके लिए we have to screen for the blood-borne viruses. ठीक है? I'll briefly touch on it, but इसको हम ज़्यादा भी कर सकते हैं. So what is अब हमने चले आपको स्क्रीन कर दिया और अब स्क्रीन करने के बाद we think that you are fit to work. You have started working. Now the role comes of occupational health in the post-employment side. आप आ गए जॉब में, अब क्या है आगे? अब हमारा एम क्या, हम कर क्या रहे हैं यहाँ पे? हमने पहले देख लिया कि आप ठीक है. But now it's the continuity of the thing. That we help you कि आप एक ऐसी environment में काम करें where you are not a risk to yourself and not a risk to others. ठीक है? So going forward, what do? Occupational health, wherever you go, is a confidential service. Confidential service means हमारे notes are not shared by anybody else. Whatever information we get from our employer, I'll call them the police, whatever information we get from them, that information is very securely secured, or the notes are put in an area which is not shared by any other hospital notes. We follow the guidelines for the GDPR, for the consent, and even जो हमें information दी जाती है, we cannot pass it to anybody without their consent. There are very few, I would say, exceptions जहाँ पे हम वो information आगे pass कर सकते हैं, but that would be depending if there is safety involved. And I can give you a small example. If anybody remembers, there was a case in Scotland जहाँ पे एक bus driver ने lorry driver था और उसने hit किया, and because he just collapsed in the bus. So at that time the occupational health was actually called to task, and they were asked कि आपको क्यों नहीं पता चला कि ये बंदा जो था he had these problems. But I think the issue is कि वहाँ पे it's safety critical. One is a driver, अगर उसको कोई ऐसी problem है जिसमें वो suddenly collapse कर सकता है, तो उसके लिए एक लॉरी चलाना और एक मेन मोटरवे पे लॉरी चलाना या सड़क पे लॉरी चलाना और वो उसमें collapse कर जाए, तो you can very well imagine वो कितना damage cause करेगा. So that's a safety critical thing. उसमें ये है कि you can override the consent and you can say no, I need to inform the DVLA, or वहाँ पे तो कर DVLA, but I need to stop you from driving. So हमारे पास जो cases आते हैं वो normally आते हैं as management referrals. Now management referrals क्या है? आप लोग काम पे हैं, everybody is working, things are good. Now suddenly आपके जो line manager हैं, they start to feel that one of the doctors or the nurses or any other, they are struggling at work. ठीक है? क्यों struggle कर रहे हैं? Maybe burnout, maybe mental health issues, maybe a physical issue. We don't know. ठीक है? And a lot of time, I think we as doctors, we find it very difficult to talk about these things. हम मरीजों को ट्रीट करने में तो बहुत ठीक होते हैं, लेकिन जब हमारी अपने ऊपर बात आती है तो we are very reserved. हमें लगता है कि नहीं, हम बिल्कुल ठीक है, हमें कुछ नहीं हो सकता. So we don't talk about these things. Now that is where the role of occupational medicine comes. The जो management है वो हमें refer करती है, वो हमें बताती है कि भाई हम एक बंदे को आपके पास refer कर रहे हैं और उसका हमें एक बड़ा brief सा दिया हुआ होता है कि उसको जो है burnout for example. So then after that what do? हम उसको अपने we call them for consultation, और उस consultation में हमारे पास actually time ज़्यादा होता है as compared to the GPs. GPs normally have 10 minutes for a consultation, isn't it? So we have got an hour जिसमें हमने उसको assess भी करना है और assess करने के बाद हमने report भी लिखनी है वापस. So that is how जो NHS है, ये जो हमारा वहाँ पे system है, that works for the healthcare staff. I will go a little bit in detail about this one, लेकिन before that मैं आपको ये बताऊँ कि हमारा एक और जो बहुत important है, which I think needs to be addressed, is the sharps injury. Now sharp injuries हमारे यहाँ होती हैं, I think हर जगह होती हैं, जहाँ पे भी हम sharp से काम कर रहे होंगे, injury is possible. लेकिन to my best knowledge there is no framework कि आप उसके बाद करें क्या. What I was told was कि I would welcome anything that you say. What I was told was कि अगर sharps injury हो तो कहते हैं कि जाओ जाके अपने senior को बता दो and that's it. और ये जो है sharps injury is dealt very seriously. इसकी वजह ये है कि sharp injury जो है it can cause, as you all know, it can cause blood-borne viruses. और blood-borne viruses हैं तो how would you monitor it? आपने इस आदमी को जो जॉब पे है हैड अ प्रॉब्लम, सो अब आप इसको कैसे मैनेज करेंगे? नाउ दिस इज ऑल अ पार्ट ऑफ ऑक्यूपेशनल हेल्थ, आवर डिपार्टमेंट डील्स विद दैट. ओके, सो नाउ मेरा कहना ये है कि टू एक्सप्लेन दीज थिंग्स मैं आपको ना आई विल गिव यू सम एग्जांपल्स एंड लेट्स सी कि उस एग्जांपल से आपको ये पता चलेगा कि हम करते क्या हैं एक्चुअली. सो देयर आर टू केसेस आई एम गोइंग टू डिस्कस. The first one, ये केस है हमारे पास आया स्टाफ नर्स 30-year-old एंड इसके मैनेजमेंट रेफरल हमारी बैकग्राउंड इसकी ये थी कि ये काम करती है ITU में. तो जो इसका मैनेजमेंट रेफरल था, मैनेजमेंट रेफरल हम उस रेफरल को कहते हैं जो हमारे पास मैनेजमेंट भेजती है. सो द मैनेजमेंट रेफरल सेड के देयर आर कंसर्न्स कि शी इज नॉट फिट फॉर वर्क. Okay, now why? The other line I remember was just one line written that she has got tonic-clonic seizures. अच्छा, so what we do? हमने सबसे पहले तो उसको ये कहा कि ठीक है, send her to us and we'll see. What do you think? एक नर्स है, ITU की नर्स है, tonic-clonic seizures शुरू हो गए हैं, उसको काम करना चाहिए कि नहीं करना चाहिए? करना चाहिए, नहीं करना चाहिए. तो हमारी एक उस पे है कि कर भी सकती हो, नहीं भी कर सकती. ठीक है, ओके, राइट. लेट्स सी हमारे पास उसके क्या थे. पहले मैं आपको थोड़ा सा उसका वो दे दूं कि उसकी प्रोफाइल में क्या था. इट वाज अ न्यूली डायग्नोस्ड एपिलेप्सी, टोनिक-क्लॉनिक एपिलेप्सी थी उसकी. न्यू प्रेजेंटेशन की, उसकी सीजर्स की हमारे उसका कोई टाइम नहीं था, डे एंड नाइट एनी टाइम दे कुड हैपन. शी वाज स्टार्टेड ऑन मेडिकेशन एंटी एपिलेप्टिक, लेकिन एंटी एपिलेप्टिक अभी शुरू होने के बाद दे वाज प्रॉब्ली इन द पीरियड ऑफ बीइंग टाइट्रेटेड, सो इट वाज ऑनगोइंग और अभी हुआ नहीं था उसका कुछ, मतलब शी वाज स्टिल अनस्टेबल एज इफ आई वुड कॉल इट. हमने जब उसको जो ICU टीम थी वाज वेरी राइटली वरीड अबाउट कि ये फिट है और नॉट टू वर्क इन द ICU. सो व्हेन शी केम टू अस वी हैड द डिस्कशन. वन थिंग आई फाउंड इन हर वाज दैट शी न्यू कि she is sort of not fit, but she was very, very keen to remain at work. She said कि किसी तरह is it possible that I remain at work? I know that I can't, but she wanted to. So हमारे लिए challenges क्या थे? इसके केस में challenges सबसे बड़े ये थे कि aura है ही नहीं, there is no aura, so it is unpredictable. Seizures का पता नहीं day night में किस वक्त होते हैं, again unpredictable. मेडिकेशन उसकी शुरू हो गई है, सेटल नहीं है, अगेन अनप्रेडिक्टेबल. सो इतनी अनप्रेडिक्टेबिलिटीज के साथ उसकी जॉब का सबसे बड़ा मसला ये था कि शी वाज डीलिंग विद वेरी वल्नरेबल पेशेंट्स एंड ऑल ऑफ देम वर ITU पेशेंट्स. वो एक पेशेंट को देख रही है या एक पेशेंट को अटेंड कर रही है एंड शी हैज अ टोनिक-क्लॉनिक सीजर. अब आप उसको संभालेंगे या मरीज को संभालेंगे? सो इनिशियली टू स्टार्ट विद वी डिसाइडेड दैट शी इज नॉट फिट फॉर क्लिनिकल. ठीक है जी, हमने उसको क्लिनिकल से हटा लिया. नाउ अब आपने उसको वहां से तो हटा लिया, बट हाउ डू यू हेल्प एंड सपोर्ट हर? वो कहती है कि मैं काम करना चाहती हूँ. ठीक है, सो व्हाट डू यू डू? वी केप्ट हर इन एम्प्लॉयमेंट. नाउ हाउ डिड वी डू दैट? वी एडवाइज द मैनेजमेंट शी इज फिट टू वर्क, however not for clinical, she should be placed in a non-clinical area. उसके साथ हमने 3 शर्तें और लगा दी. हमने कहा एक, she should not be doing lone working because even if she is in a non-clinical area and she has a fit, who is going to be there? So no lone working. Secondly, we said she should not be working on the heights. Now interestingly हम ये सोचते हैं कि हमारे एरिया में हाइट कहाँ से आनी. Sometimes these nurses they just have to climb few steps ladder पे, जाके ऊपर से चीजें उतार रही हैं, कर रही हैं, ऊपर जाके हो गया फिट तो उसको संभालेगा कौन? So we said no working on the heights, and the third was that she would not be doing nights because night again it affects the management of epilepsy in the uske. And then more importantly we stopped her from driving because that was a big challenge. Another important thing which you should never forget when you are an occupational health physician is there is one is the physical side that we were dealing with, the other is the emotional side. This was a big emotional trauma to her. All of a sudden आपको पता चले कि you have got tonic-clonic seizures, आपकी तो पूरी जिंदगी upside down हो गई. So we referred her to a talking therapy, and the talking therapy, they were supporting her for as as counseling and to help her through. So now what happened? She had a continuous regular contact with us. Her senior activity slowly, gradually went under control, and she became more stable. We introduced her back to the clinical environment, and more importantly, she's back to driving now. So what did we achieve? A young nurse in employment, we kept her. We allowed for the ongoing household income. We supported her financially, emotionally and mentally, allowed her time to become clinically competent again and maintain the overall working integrity of the healthcare system. We didn't lose an employee. That was the most important thing over here. So in essence, I would say that she had invested a lot of time and effort to become a nurse. We invested only a little bit, but by investing that little bit of time, she was able to continue her dream job of serving and helping in the clinical side. Now the next case I'm going to go very quickly. That was of a junior doctor, 25 years of age. Background was he's a house officer working in the medical wards. He was interestingly referred that he is struggling at work. And I have actually copied the line which I got was, constantly tired, cannot focus at work, lacks concentration, finds it difficult to complete his jobs and struggles to safely manage his patients. So what should we do? Should he continue to work or should we just kick him out? No, you can't. Okay? Right. So the issues we had over here, he was aware of the concerns, and he agreed, when I saw him, he agreed that yes, I'm struggling at work. But interestingly, he had no insight into why. I probed down in his history, and I found that there were few other incidences where he was struggling with work in the past. And also, he very briefly said that when he was a young teenager, he was taken for a psychiatric assessment, and they said that he had some mild bipolar disorder, but at that time, no medication was required. Okay, he was very apprehensive about his work, which I think we could all understand why. But all said and done, he wanted to stay at work. What were the difficulties in his case? Patient safety, as I said before, it's a safety critical role. There was no confirmed diagnosis, no psychiatric assessment available at that moment. Again, unpredictable pattern of behavior, and he had started to lose confidence in himself because he was struggling so slowly, gradually. That again makes him sort of a risk to the patients. Now, the initial decision that we did, we said that, okay, fine, he's fit to work, but how? We said he's fit to work if he's allowed to work under direct supervision for the next at least 4 weeks. Because he had lost his confidence, and this was the time for him to regain his confidence. The other thing which I asked them to take him off was the nights. Because the studies say that if there is somebody who has the bipolar disorder, working nights or changing their shifts, that can actually adversely affect their mental condition. And I think that was the nights, he was doing continuously nights, that actually flared up his underlying condition. We also referred him to the GP and to the PHP. PHP is a practitioner health program we have over there. It is basically an association by the doctors who support the doctors or the medical staff who are struggling with the mental health conditions. Later I got the letter from the PHP confirming the diagnosis of bipolar disorder and then letting us know that he has been started on medication, and the other treatment for that is the psychological therapy which he was receiving. So today he's working back as a full-time doctor, works independently, no further concerns regarding struggling at work, keeps regular contact with our team but only when it is required. And one thing, he's still remained off the nights. So reflecting that, the only thing I can say is that not in every case we are able to 100% bring a person back to their baseline to work. So there still be some adjustments that might be required to keep them at work. I haven't here, yes. Now, in this young doctor again, Obviously, the income, employment, everything is there. But I think the important thing over here, which I wanted to bring home was, this is a junior doctor whose actions anybody could have easily dismissed as being lazy. They would have said, oh, he just doesn't want to work. Or that is how he was actually referred to us. He was not lazy. We had time, we had the expertise to evaluate his case, identify his underlying problem. And when we were able to identified his underlying problem, we supplied him with avenues of support, like PHP, the GP, and then when he was treated, he became a fully functioning member of the healthcare team. There are some interesting stats, just one line I would like to discuss, and that is, if you do not actively engage in managing this sickness, 20% of the staff will not come back after 4 weeks of being off sick, and 80% of the staff will not come back after being off sick for 6 months. So there should be somebody who is actively engaged in sorting them out. We occupational health physicians are sitting between the employee and the employers. We are the advisory service who help and guide the employees in need, and we advise the management on how to best help and support them staying at work. We are governed by the laws, safety laws, health and safety laws, and the employment laws. And I think in Pakistan, this is something which is actually lacking from the medical point of view, from our own medical system as well. It is not that only industry needs it. I think we as healthcare workers probably need it more. So that is the message to take home, and I think we are open to do this. There was from you.
Yeah, because we have a lot more here. We do not know what happens to them. We do not know what happens to them, and we do not know who would basically comply all these things. But you had recommended. We would listen to our seniors later on the same issue. The general practitioner, the 10 minutes time, आपके पास 10 मिनट होते हैं, उनके पास 1 घंटा होता है, बड़ा प्रॉब्लम है. लेकिन मामला ये है कि I just want to understand that if you write somebody as fit or as sick, even then would he or she be referred to the occupational health services, and can they overrule your fitness or sickness? We would like to listen from you in this particular talk. And now I invite Dr. Zainab Hafiz. She will talk about the GP training and services delivery in the UK.
Thank you very much, sir. आपने बड़ा अच्छा stage set कर दिया है for the presentation. जी, service delivery. So जैसे कि सर ने कहा कि I'm going to talk about GP training and service delivery in the UK. It's a very broad topic, mammoth topic. So I understand there are time constraints, so I'll just try and touch on a few things and cover as much as possible. So what we're going to talk about today is what is primary care or general practice, pros and cons of doing primary care, GP training in the UK, and then service delivery. So what is general practice? A fair bit of health and surgery dikhaya. I've just sort of amended it a little bit. But because what we believe in health sector now is that preventive services, health promotion and disease prevention, community care, health prevention, health promotion and disease prevention, including public health policies, and then comes primary care. What I would think is that in UK we have incorporated the two into one. We do a lot of health promotion and disease prevention in primary care. What we actually believe is that every contact with the patient is an opportunity for health promotion in some form or the other, and for disease prevention, rather than just treating them for an acute or chronic condition. And then at the tip of this pyramid is secondary and tertiary care. So 90% of the consultations take place in primary care in UK. So general practice, I've taken this from NHS England website. Our people, means GPs, are meeting the challenges of growing and aging population with the next generation of proactive, preventative healthcare, education, advice and treatment. We want to give patients earlier diagnoses and more lifelong control over staying well their way. That is also very important. What is at the heart, or what is the core thing in general practice is doing the patient-centered consultations and doing the right thing, but doing it their way, doing it the patient's way. So GPs and practice teams provide vital services for the patients. They are at the heart of our communities, the foundation of the NHS. So, as I said, bulk of UK doctor consultations in general practice, almost 90% of the consultations via NHS, they happen in general practice. So I'd say that GPs or primary care physicians or family physicians are the gatekeepers of NHS, and general practice is the gateway of the NHS. So a few terms to define GPs. Historically, traditionally, in UK, they're called general practitioners. Family physician, more common in Northern America, Canada. A new emerging term, consultant journalist. I think that is more because in certain cultures, in certain countries, being a consultant is considered more prestigious. So perhaps this is an emerging term, consultant journalist. And GP surgeries are independent businesses. I'm going to talk a little bit more about it when we talk about service delivery in the UK. But this is just to give you a broader idea of what general practice is in UK. So pros of general practice. I think it's a very flexible job. And when I say flexible, it is flexible in every sense of the word. You can choose the days you want to work. If you want to work during the working week from Monday to Friday, or if even you want to do the weekends, there are out-of-hours services, emergency GP services that you can work. Some of you, if they prefer to work nights, they can do nights and not any day work at all. And then about the timings, you can do half days, morning, afternoon, or evening surgeries. So it's really flexible about how you want to work, when you want to work. And then there is another sort of dimension to this flexibility about what sort of work you want to do. As Dr. Varda nicely mentioned, sort of gaining more expertise into occupational health. You can be a GP with special interest. If there is anything that fascinates you more, like if you are a female GP and you want to be a GP with special interest in gynae, you can be a GP with special interest in cardiology, dermatology, rheumatology. So there's a lot of flexibility about having a special interest. Then there's flexibility about having a portfolio career. You can teach, train, work as a doctor. There's a lot that you can do in terms of what sort of work you want to do, when you want to work, and when you not want to work. If you want to do fixed contract, if you want to be a bit more flexible and work as locum, as and when you want to. And then range of medicine. I think it's very fascinating to be a GP. You are sitting in your room and you don't know what can come through your door. Endless possibilities. You can, in the same surgery, you can see a patient with a condition as simple as olecranon bursitis, and the next patient coming in might be actually having a heart attack. So it's quite diverse. If you like diversity, if you like new challenges all the time, अगर same चीज़ आपको bore करती हैं, I think general practice is the field for you. You'll never get bored. You'll see new things all the time, including the social problems, socio-economic problems. It's really diverse. And then there's continuity of care. Because you're a family physician, you're sitting in the same area most of the time, So you're not only treating one patient, you are literally treating families, generations. You can refer your patients, if appropriate, to secondary or tertiary care for specialist input, but they'll always come back to you. And in some cases, I think it's interesting because we have that long-term relationship with our patients. Sometimes even when the specialists or the consultants tell them something, they literally come back to us in a week or so, and they sort of discuss and verify things with us, which actually has never ceased to surprise me. How much that good rapport with your patients, how much they trust you, how much they look up to you, and how much they really want to see you and get your advice, even about the matters that have been discussed in the secondary or tertiary care. As I said, you can choose your working time, working hours, days, and then you have time to do other things. If you have other interests, like if, let's say you want to pursue music or something else, you want to join a reading club, you can tweak things a lot. I think, and that is the beauty of general practice. Hospital consultants have some degree of flexibility in their role, but definitely not as much as a GP, as an independent, as we have as independent practitioners. Like I am staying in Pakistan for the last year and just go there every now and then and do locums, and which is absolutely fine if this is what you want to do. Cons of general practice, or perhaps more perceived cons of general practice. I put question marks in front of some of them. One of them is, do you think you would miss acute work in general practice? Some people, they really need a lot of adrenaline rush that you get from bungee jumping or skydiving. If you're that kind of person, then perhaps yes, if you want to do tracheostomies and if you want to deal with major traumas, then yes, you'd miss that sort of acute work in general practice. But if you're okay with MI, then PE, then sepsis, you'll see that in general practice as well. But yes, if you need a lot of adrenaline rush to keep you going, and you're going to miss that kind of putting chest drains in, and then yes, general practice is probably not for you. You should be in A&E or in more sort of secondary or tertiary care settings. Then loneliness, because we work as independent practitioners, so you're pretty much sitting in your office. You are seeing the patient, you're dealing with them, and you are taking the clinical decisions. It can be, it can take its toll, and it can be a bit daunting sometimes because you're seeing the patient. I think now the practices are becoming bigger. There are bigger teams, so you have support from your colleagues. There are regular practice meetings. But yes, at the end of the day, because you are an independent practitioner, you are taking decisions for your patients, obviously you're including them in, it's sort of mutual decisions, but because you're dealing with them on your own, in your office, or in your consultation room, so that can be a bit lonely perhaps sometimes. While some people feel that because hospital teams are much bigger, you're in secondary care, you're in tertiary care, so they feel that, okay, we have a bit more support there. Then responsibility, there is a lot of responsibility. I think when people say that GPs only treat coughs and colds, and then I say to myself, perhaps you've not worked enough in general practice to know what sorts of things do we treat and what sorts of patients do we deal with. There is a lot of variation in terms of the areas where you work, in terms of ethnicity, in terms of health problems, in terms of people's socioeconomic backgrounds. But yes, a lot of responsibility in terms of not only treating patients for different illnesses, for health conditions, but also in terms of, as Dr. Bhatta said, about their emotional health, mental well-being, and then even a broader role in terms of safeguarding not only for children, but for vulnerable adults. It's a lot of responsibility. If you are doing your job honestly, I think being a general practitioner or being a family physician is a lot of responsibility. I put a question mark for de-skilled. Some people think that, oh, you can get a bit de-skilled in general practice. There's a lot that you can do. If you like procedures, you can do minor surgery. Yes, but if you like bigger procedures, then perhaps you need to be in a hospital setting for that. I've already spoken about only treating coughs and colds. I don't think that's the case. You'll literally be treating anything and everything, starting right from picking up sort of quite the cancers coming in with vague symptoms and a lot of health conditions. And there's a lot of onus and responsibility on you as a primary care physician in terms of patients' physical and mental well-being. So GP training in the UK, I'm going to briefly talk about it. It might be a novel concept for a lot of students here, but just to familiarize you a little bit with the entire concept, I think it's a pretty big topic, vast one, but I'm just going to go quickly through a few points. So minimum 3 years specialty training, as GPST means GP specialty training. There are conversations about increasing it, the duration, making it sort of bringing it on par with other specialties. I think it's going to be 5 years, but when, I don't know. At the moment, it's 3 years specialty training. So what you need to do is to maintain a training portfolio, quite elaborate portfolio online, and clear ARCP, annual review of competence progression every year. Usually what happens with GP training is that there are 18 months in an approved training practice, and the remaining months in hospital rotations, which will include rotations like pediatrics or gynecology, general medicine, acute medicine, A&E. There are some innovative posts now where you split your weeks between hospital and GP practices. You need to achieve MRC GP to successfully complete the training. With the GP training, at least in UK, there are limited attempts for MRC GP exams, which is not the case with any other exam, with any other medical exam. You can try and take it as many times as you want, but with MRC GP, limited attempts, and you have to clear it to be able to work as a GP, and you get CCT or Certificate of Completion of Training at the end. So GPST1, 3-year pathway. You'll do your first 6 months, and then you'll have a review with your educational supervisor that is called ESR, Educational Supervisor Report at the end. At the end of 12 months, an ESR and annual review of competence progression, that is ARCP. In GPST2, you are eligible to take the first step or first exam of MRC GP, that is AKT. So AKT window is 24 months, ST2 and ST3. So then again an ESR at 18 months and then at 24 months, ESR and ARCP. So in GPST3, you are able to take the second step or the second exam of MRC GP. That was CSA or Clinical Skills Assessment. But now due to COVID, they have changed that because the clinical skills assessment was a bit more like OSCE, a clinical exam where you do the consultations with patients and examiners will observe you. That's been changed to RCA or Recorded Consultation Assessments since the pandemic, and I think they're bringing changes to it that would be implemented in the next year or so. So eligibility criteria. You need to obviously have an MBBS degree. You should have full registration and whole license to practice from GMC at the time of intended start date. Should have evidence of achievement of foundation competencies in the 3.5 years preceding the start date. So foundation competencies are like, you need to have some, foundation program is like the house job. So it's 2 years program, F1 and F2. You need to have some basic competencies, and if you are doing the foundation program, you maintain an e-portfolio and you have all those competencies anyway. You do the procedures, the simple procedures, and you will go along your posts. But even if you're not doing the foundation programs, there are ways to achieve the competencies. So obviously you need at least 2 years of clinical experience or the equivalent to foundation program before you start the training. You should be eligible to work in UK and should have UK driving license or an alternative transport agreement. So application and assessment, 2 rounds each year. There's a February start and August start. So coordinated by a national recruitment office. So it's a national recruitment program, GPNRO. And you can fill in application through recruitment portal, that is Oriel, an online application. If you meet the eligibility criteria, so you are invited to do an assessment, a written assessment, a multi-speciality recruitment assessment. So it has got 2 papers, a professional dilemma and a clinical problem-solving paper. there was a third stage initially, but since pandemic they have not done it. And so they add marks from your application from the second stage, that is MSRA, and then the third one. But now there are just 2 stages, application and the written exam. If you clear them, then obviously you're eligible to start the training. So the second thing is general practice service delivery in the UK. So I'm going to talk a little bit about contracts, because as I said earlier, GP practices are independent businesses. So just to talk a little bit about how these small to medium-sized businesses work, how do they get funding, and how they're contracted. So the way general practices are contracted and funded is quite complex and very different from other parts of the healthcare system. To be honest, a lot of GPs even working in UK, because if you're a partner, you're involved in this contract and business side of things, a lot of the physicians who are working don't know exactly how do these things work, and it's quite complex. So as I said, small to medium-sized businesses whose services are contracted by NHS commissioners to provide generalist medical services in a geographical population area or a population area. Actually, I'd say it's complex, but it's quite fascinating, to be honest, how they've created this system over the last 6 to 7 decades, how it has evolved, how there's been ups and downs, and how it has improved, and some of the things are taken out and some have been put in. And really in an attempt to make it a better, a more robust system. So core parts are, what's a GP contract? Done by NHS England, but as I said, GP surgery work as independent businesses. So the core parts in a contract are the geographical and population area the practice will cover, practice to maintain a list of their patients, establish the essential medical services the practice must provide to its patients, set standards for premises, workforce, and requirements for inspection and oversight. So the basic contract is how you provide the services, if you've got the premises, if you've got the qualified staff, set out expectations for public and patient involvement, which is at the, as I said earlier, heart of general practice, getting feedback from patients, patient questionnaires, involve them in the service so they feel a part of this local service in their community. On outline key policies including indemnity, complaints procedure, liability, insurance, and clinical governance. In addition to these core agreements, a general practice contract also contains a number of optional agreements. They are like local enhanced services and directive enhanced services. So these are on the top of your basic contract, where you're providing the basic services to the patients. For example, some practices for H. pylori, they want to do urea breath test. That in some area there's a locally enhanced service. So you can do that for your patients. You can provide a service and you can get some extra money for providing that service. Now the question is, why do I talk so much about money? Because I think the realistic thing is, no matter whatever your motivation is, how compassionate you are, at the end of the day you need some funding to be able to run a service effectively, especially long term, because you need to meet certain standards that Dr. Varda has talked about, occupational health. So funding is a complex mix of different income streams in general practice. Commissioning responsibility sits formally with NHS England and NHS Improvement, but there is a role of some local bodies. We can just leave it because I think it's just too complicated and there are time constraints. So how do GPs get the bulk of their income, or how does general practice is paid in global sum payments? Actually, majority of the money, or at least more than half of the money in the practice is from global sum payments. And that they get for delivering the core parts of its contract, the contract I've just spoken about. It is based on an estimate of practices, patient workload, and certain unavoidable costs. For example, if you're working in a rural or remote area, that might be more expensive, and the effects of geography on staff salaries. So these things, there's a very complex Carr-Hill formula. I have not included it because I think they're complex things, and that's how the global sum payments are calculated. The bulk of the money that NHS that is paid, I think eventually through the umbrella of NHS England to individual general practices comes from global sum payments. Then there are certain incentives for GPs. So the policy makers, and they keep looking into things, both to improve patients' health, population's health, global health, and then how to incentivize doctors to be able to do that more efficiently long term. So they have made certain indicators like quality and outcomes framework payments. Around 10% of the practice income comes from this sort of cost. If the practices are doing cost properly, then around 10% of the income comes from that. Voluntary program that practices can opt into in order to receive payments based on good performance against certain indicators. For example, certain indicators like if you are reviewing your asthma patients annually, if you are treating your hypertension patients, if their blood pressures are controlled, if you are doing annual reviews for your diabetic patients, their sugar levels are below certain limits, because that's really, really important for population's health. Then you get to premises payment, the payment for your building, to maintaining it, and there are income streams via teaching and training. There are primary care organization administered payments, so you can get certain payments for temporary doctors via CCGs. So all in all, if you talk about income and then outgoing, you see that income is via global sum payment, income for providing some contracted services, then quality and outcomes framework, training, primary care organization payments, then IT and premises, and then you can look at outgoing office costs and IT, clinical consumables, like if you're using bandages and certain medicines used in general practice, ECG machines, then building costs and staffing costs, their salaries, and then internet and this kind of costs. And how GPs are paid salary, GP through salaries. Partners who own the business, actually they get the leftover practice income shared between them, which is used to do the payment, tax, indemnity, and drawings. So, you can see that if you look at what I have said, GP practices look like quite individual entities, which actually they are. But then we need the tools in NHS Armory or NHS England broadly to support individual practices. There can be lots of problems. They're small to medium-sized businesses. So the tools are like we have groups for neighboring practices, for 6 to 8 neighboring practices, coming under the umbrella of care delivery groups or now PCNs, primary care networks. There are local medical committees. If you need any legal guidance, staffing problems, anything, you can get to them, and they're quite good. Normally, local medical committees, the regional bodies. Then there are robust IT systems. I think that is very important and helpful. We get good medical records, and then patient-centered care, primary care plus community care, combining them together. So we get a lot of help from district nurses, pharmacists, opticians, optometrists. They are the concept of polyclinics now, where under one roof you get different professionals working together. So primary care and community care working together. There are safety systems such as out-of-hours primary care services if our patients become unwell. Then there are national guidelines like NICE and SIGN that we follow when treating our patients, which helps because then we know that we are doing the right thing. So I'm not prescribing a random drug for hypertension and the colleague sitting in the next room is not prescribing another drug. We are following certain guidelines, so we're quite aligned when we work in British general practice. And then there are local guidelines where they are needed, for example, in terms of antimicrobials due to the local resistances. And so we just try and follow those guidelines broadly. Obviously, physician instinct and all that comes into play as well. So regular teaching and training, both for medical and non-medical staff members, annual appraisals for qualified GPs, nurses, ANP, grade CS, and other staff. Thank you.
सर मैं आपकी पेशेंट्स को सलाम करता हूँ और मुझे पता है कि आज आपको मेरे डांट पड़नी है पिटाई वो are they paid by the government or the NHS or whatsoever, so we can't
काम तो इतना है कि
there are the patients
patients, are you asking if patients pay us? I think patients pay the tax so that they feel quite entitled to come to us anytime and every time they want to. It's hard work. It's a lot of hard work.
Thank you, ma'am. Thank you. We would have certain मतलब अभी हम अपना setup देखते हैं कि हमारे यहाँ क्या हो रहा है इस सारे setup के बाद, and then we would have some question answer from our participants. So the general practice in Pakistan now, and we have a very again learned speaker, Dr. Naeem Majid. He is actually involved in the immunizations and the health governance system in Pakistan and based in Lahore these days. We would like to listen to him about the GP training and service delivery in Pakistan. Dr. Naeem Majid sir.
One thing, it's worth it. Burnout is least reported in occupational health physicians. It's a very family-friendly job. No on-calls, no emergencies, no nights. It's
once you have
oh yes, that goes through the faculty. Accountability is not only through the faculty, because as I said, अगर आप लोगों को याद हो कि ये clinical भी है और law भी इसमें involved है, इसलिए कि आप employment law, health and safety से करते हैं. So there are times that you can be called into the tribunals and they can ask you questions कि जी आपने फलाने का ये किया तो ये ऐसे क्यों किया? But I can still assure you कि 99% of the time the occupational health is it stands out and they say that they were the right one. So there is accountability through the faculty as well as the legal system as well.
Is there any role of the psychiatry or psychology involved in your curriculum in this and that, or it's just like you have to counsel a lot of things and you have to listen to somebody for 1 hour and this and that? Do you have some special training for all these sessions and these things?
When you train for occupational medicine, you have training. It's like, in simple words, I often call it as a jack of all trades, master of none. But you have training into everything. We do not make decisions. Decisions in the sense that if I find, like the second case that I discussed, where I knew that this is bipolar, it has come back and it has come back with a vengeance. I did not make the diagnosis. I only give a provisional one that is what I think it is, and on the basis of that, I'm taking him out of the night rota. I referred him to the proper services because we, as you can see, we see all kind of people. And I've only touched the healthcare sector. When you go out of the healthcare sector, it's anybody who is employed anywhere. We see them. So we do not make decisions on there, or we do not make formal diagnosis, but we can make provisional, and according to that we refer them to the services which are involved in the care.
Any question from the audience?
Oh, I have got in fact a personal kind of a little case to share really,
Yeah,
which
sure.
has been really thankful to the occupational health department. One of our doctors, one of my trainees, was from Karachi. He was really struggling. He was 10 years post-graduation and he was struggling. And I couldn't really figure it out. What is wrong with this person? He's not lazy, he's very dedicated. He comes to the work, but he is not really making right kind of decisions which were expected of him. He was failing in his exams. So, and he completed his 3 years, so he was going to go nowhere. Basically, he was ending for a disaster. And sent him over to the occupational health department. They kind of worked it out. This fellow ultimately was diagnosed as dyslexia. And then he was provided with 6 sessions of proper coaching. After that, he was given extra time during his AKT, which is applied knowledge test, which they have to do, 25% more time. And he needed another extra year. And then finally actually made it. And this fellow is actually now practicing as a GP. Well done to you.
Thank you very much. And thank you for mentioning this case, especially when he said that the doctor came from Pakistan. We do have people coming from Pakistan and from different areas of the world, starting in the NHS practice. And I wasn't actually thinking that he's going toward the dyslexia side, because the problem which we face is that they are not aware of the system as such. And when they start, they're just thrown directly into the system. And that makes it very difficult for them. Given time, they do get used to it and they start working into the system. But I think some initial support, as I said, that when we do the pre-employment, that is the time we sit down with them and we ask them all these kind of questions, what they have done, what they haven't done, any physical ailment they have, any mental thing that has. And again, as I said, that we are a very confidential service. There is no way that anybody else, even the people who are involved in their care, they cannot have the notes out for them unless we have their consent that they can do. So we are here basically to support the employees of and as I said, the healthcare workers.
Thank you, ma'am. Now let us have the experience of Dr. Naeem Nadeem for the general GP.
About Pakistan, we don't have a very structured general practice system in Pakistan. I will outline now what we are doing. I am working with the government of Punjab for the last 15 years in various policy reforms on maternal health, child health, immunization, etc. My current role is with the Bill and Melinda Gates Foundation, and I am providing technical support to government of Punjab on various immunization programs of the government. So, in Pakistan, the public sector, we have two different health systems. One is the public sector health system and one is the private health system. The public sector health system, which is much regulated and organized, while the private health sector system is not so much organized and it is not so structured as well. So, जो हमारा गवर्नमेंट का सिस्टम है, उसमें हमारे पास प्राइमरी हेल्थ केयर फैसिलिटीज़ हैं और सेकेंडरी हेल्थ केयर फैसिलिटीज़ हैं और टर्शियरी हेल्थ केयर फैसिलिटीज़। ये बेसिकली 4 लेवल्स हैं हमारे पास गवर्नमेंट में। एक पहला है जो कम्युनिटी लेवल है, जिसमें हमारे पास कम्युनिटी में हेल्थ वर्कर होते हैं, वो मैं आगे आपको बताऊंगा कौन कौन होते हैं। उसके बाद जो प्राइमरी लेवल है उसमें बेसिक हेल्थ यूनिट्स और आरएससीज हैं, जहाँ पे ओपीडी केयर है, बेसिक इंडोर है, थोड़ा सा आरएससीज पे, और ऑब्स्टेट्रिक सर्विसेज हैं, ये भी आगे डिटेल में आएगा। इसके बाद हमारे पास सेकेंडरी लेवल है जो कि तहसील हेडक्वार्टर और डिस्ट्रिक्ट हेडक्वार्टर हॉस्पिटल्स हैं। 50 से लेकर 200 बेडेड हॉस्पिटल्स होते हैं जनरली, जो तहसील लेवल पर या डिस्ट्रिक्ट लेवल पर होते हैं। और उसके बाद जो फोर्थ लेवल है हमारा, वो टर्शियरी केयर है, जिसमें जैसे गंगाराम हॉस्पिटल है, जिना हॉस्पिटल है, वो है, बाकी सारे टीचिंग हॉस्पिटल के साथ जितने भी टाइप हैं वो सारे हमारे टर्शियरी केयर में आते हैं। ये 4 टीयर्स हैं हमारे पास सिस्टम्स के। इसमें जो जनरल प्रैक्टिस है वो हमारे पास पहले 2 में ज़्यादा बेहतर है। जो हॉस्पिटल है वहाँ पे जनरल प्रैक्टिस का कॉन्सेप्ट उस तरह से नहीं है कि एक ओपीडी होती है, वहाँ पे जाते हैं, वहाँ से हम फ़ौरन उसको स्पेशलिस्ट के पास भेज देते हैं। मेडिसिन का केस है तो इंटरनल मेडिसिन में भेज देते हैं, सर्जरी का तो सर्जरी में भेज देते हैं, गायनी का तो गायनी में, और पीडियाट्रिक्स का तो पीडियाट्रिक में। ये 4 बेसिक हैं। उसके बाद आगे फिर फर्दर क्लासीफाई आप कर देते हैं उसको कार्डियोलॉजी में, ऑर्थोपेडिक्स में, जिस तरह से भी केस की वो रिक्वायरमेंट होती है। तो जो फैमिली मेडिसिन की स्पेशलाइजेशन है वो हमारे पास सीपीएचसी की तरफ से मौजूद है, लेकिन उसकी एज ए एडमिनिस्ट्रेटिव टाइटल हमारे पास नहीं है। मतलब किसी भी सरकारी हॉस्पिटल में आपको फैमिली फिजिशियन की पोजीशन नहीं मिलेगी। आपको सीनियर रजिस्ट्रार सर्जरी मिलेगा, सीनियर रजिस्ट्रार मेडिसिन मिलेगा, लेकिन सीनियर रजिस्ट्रार फैमिली मेडिसिन नहीं मिलेगा आपको कहीं। ये पोस्ट ही एग्जिस्ट नहीं करती है हमारे पास पब्लिक सेक्टर। प्राइवेट में भी सेम है, क्योंकि वो भी गवर्नमेंट को फॉलो करते हैं, तो वहाँ पे भी फैमिली फिजिशियन की जो पोस्ट है वो एग्जिस्ट नहीं करती। इसमें जो प्राइवेट सेक्टर है उसमें तो जैसे आप लोगों को पता है कि कोई भी जो डॉक्टर है वो एमबीबीएस करता है, उसके बाद पीएमडीसी की अपनी रिक्वायरमेंट पूरी कर लेता है, हाउस जॉब भी 1 साल की, तो उसके बाद वो अपना क्लिनिक खोल सकता है, और उसी को जनरल प्रैक्टिस हम यहाँ पे कहते हैं। इसमें कोई उसको रिक्वायरमेंट ऐसी नहीं है कि वो फैमिली फिजिशियन की पहले ट्रेनिंग पूरी करे या कोई भी और ट्रेनिंग करे। वो सिंपल एमबीबीएस और लाइसेंस लेने के बाद अपना क्लिनिक खोल सकता है और जनरल प्रैक्टिस स्टार्ट कर सकता है। इसको रेगुलेट करने के लिए हेल्थ केयर कमीशन हैं, सारे सूबों में मौजूद है। पंजाब वाला सबसे ज़्यादा एडवांस्ड है, बाकी प्रोविंसेस अभी प्रोग्रेस कर रहे हैं आहिस्ता आहिस्ता। पंजाब वाला भी एडवांस होने के बावजूद अभी काफ़ी वीक है। सारे जितने भी हमारे जीपीज हैं उनके साथ लाइसेंस अभी नहीं है, रजिस्टर्ड सारे हैं। इनका जो हेल्थ केयर कमीशन का सिस्टम है वो ये है कि पहले वो रजिस्टर करते हैं, उसमें आप सिर्फ अप्लाई करते हैं, अपना नाम और एड्रेस और क्लिनिक का एड्रेस देते हैं, और PMDC का लाइसेंस देते हैं, उस पर वो आपको एक रजिस्ट्रेशन नंबर दे देते हैं। उसके बाद उनकी कुछ रिक्वायरमेंट्स हैं, मिनिमम सर्विस डिलीवरी स्टैंडर्ड्स हैं जो कि आपने पूरे करने होते हैं, और उसके बाद आपकी असेसमेंट करेंगे और फिर आपको कंप्लीट लाइसेंस या एक्रेडिटेशन जो है वो दे देते हैं। तो जो एक्रेडिटेशन है वो अभी काफ़ी सारे डॉक्टर्स की नहीं हुई है, काफ़ी सालों से पेंडिंग है, क्योंकि हेल्थ केयर कमीशन के पास कैपेसिटी नहीं है, हमारे पास जो प्राइवेट सेक्टर है बहुत बड़ा है, वो तकरीबन 4000 के करीब छोटे और बड़े हॉस्पिटल और क्लिनिक्स मिला के हमारे पास हैं पंजाब में सिर्फ। बाकी प्रोजेक्ट्स के भी अगर आप देखें तो ये अराउंड 8-9,000 पाकिस्तान पूरे में बने, तो उन सबको विजिट करना फिजिकली जाके और लाइसेंस करना, लाइसेंस करना, ये काफ़ी बड़ा काम है जो कि हेल्थ केयर कमीशन के लिए अभी वो स्टेप वाइज कर रहे हैं, लेकिन टाइम लगेगा इसमें। तो जो हमारा प्रॉब्लम था प्राइमरी हेल्थ केयर में या जनरल प्रैक्टिस में, वो ये था कि रूरल एरियाज में या जो हमारे अर्बन चलाम है वहाँ पे डॉक्टर्स नहीं जाते, बेसिक हेल्थ यूनिट पर डॉक्टर नहीं जाते थे, RSCs में नहीं जाते थे। लेकिन ये बात अब पुरानी हो गई, अभी मैं आपको आगे फिगर्स भी दिखाऊंगा। तो ये इस पे गवर्नमेंट काफ़ी अरसे से काम कर रही थी। 2015 से फिर उन्होंने कुछ रिफॉर्म लेना स्टार्ट किए, जिनमें सबसे पहले उन्होंने फंक्शनैलिटी को इम्प्रूव करने के लिए कुछ बेसिक चीज़ें, मसलन वहाँ पर हाथ धोने के लिए पानी नहीं होता था, साबुन नहीं होता था, पीने के लिए पानी नहीं था, डॉक्टर के बैठने के लिए चेयर वगैरह नहीं थी। इन चीज़ों को इंश्योर किया, इनपुट्स प्रोवाइड करना स्टार्ट किया 2015 से, उनको मॉनिटर करना शुरू किया। इसके बाद एक जो बड़ा एक चीज़ थी वो थी ट्रेनिंग पॉइंट्स, जो आप लोगों को सबको पता होगा कि CIP में जब आपकी सेंट्रल इंडक्शन होती है तो उसमें आपको नंबर मिलते हैं, अगर आप बेसिक हेल्थ यूनिट या रूरल हेल्थ सेंटर में रूरल एरिया में जाकर सर्व करते हैं। 6 महीने के 5 नंबर हैं, 1 साल के 10 हैं, 1.5 साल के 15 हैं और 2 साल के मेरे 20 हैं, तो मैक्सिमम 20 उसमें स्कोर में थे। तो ये जब से ये स्कोरिंग वाला सिस्टम स्टार्ट हुआ है, तो इसके बाद आगे मैं आपको ग्राफ में डाटा दिखाऊंगा, तो आप देखेंगे आप हमारे पास एक सीट हम अनाउंस करते हैं तो उसमें 100-150 डॉक्टर होते हैं जो कि जाना चाहते हैं वहाँ पे, और इवन डीजी खान राजनपुर के रिमोट एरिया में बच्चियाँ जो है वो भी जाने के लिए तैयार हैं, सिर्फ इसलिए कि वो उनका जो मेरिट है वो बन सके। इसके अलावा और इसमें फिर सेंट्रल हायरिंग हम बीच में करते रहे, बीच में प्राइवेटाइजेशन पे भी काम होता है, जिसमें PRSP पंजाब रूरल सपोर्ट प्रोग्राम पहले था पंजाब में, पाकिस्तान पीपल्स प्राइमरी हेल्थ इनिशिएटिव के नाम से PPHI था, ये लोग भी करते रहे काम। इसमें बेसिकली प्रॉब्लम हमें ये था कि जो गवर्नमेंट की हायरिंग है वो पब्लिक सर्विस कमीशन के थ्रू होती है या वो एडहॉक के थ्रू होती है, तो उसमें काफ़ी सारे चैलेंजेस है, उसमें रिस्ट्रिक्शन है, उसमें एज की लिमिटेशन है, उसमें आप फॉरेन हायर नहीं कर सकते, फॉरेन फायर नहीं कर सकते। तो इन चीज़ों को एड्रेस करने के लिए गवर्नमेंट ने फिर NGO टाइप गवर्नमेंट NGO बनाई पीपल्स प्राइमरी हेल्थ इनिशिएटिव के नाम से, जिसको उन्होंने ये मैंडेट दिया कि बेसिक हेल्थ यूनिट्स और RSCs पे आप डॉक्टर्स की प्रेजेंस को इंश्योर करें। तो वो डॉक्टर्स को फॉरेन हायर करते थे, आज आप गए अपना लाइसेंस लेके तो अगले दिन आपको वो एम्प्लॉयमेंट पर रखते थे, तो जैसे ही आपने छोड़ना है, आप 1-2 दिन का नोटिस दें, आप छोड़ के चले जाए। और इसमें उन्होंने रोटेशन वगैरह भी की कि एक डॉक्टर अगर है और 3 हेल्थ फैसिलिटीज है, 2-2 दिन वो तीनों जगहों पर उसको रोटेट भी करते हैं। तो डिफरेंट चीज़ें हमने पायलट की हैं। पंजाब में आप पंजाब हेल्थ फैसिलिटीज मैनेजमेंट कंपनी के नाम से ये लोग काम कर रहे हैं। जब ये स्टार्ट हुए थे तो गवर्नमेंट की सैलरीज कम थी, इन इनिशिएटिव्स की ज़्यादा हुई थी, लेकिन गवर्नमेंट में अब क्योंकि काफ़ी सारे अलाउंसेस आ गए हैं, सैलरीज बढ़ गई, तो इस वक्त जो गवर्नमेंट का एम्प्लॉयड डॉक्टर है उसकी सैलरी ज़्यादा हो गई है और जो कंपनी का था उसकी कम है। तो अब ये भी एक रिफ्ट दोबारा से, पहले रिवर्स साइड से थी, अब दूसरी साइड से रिवर्स हो गई है कि इनकी काम होकर ज़्यादा लोग अब गवर्नमेंट पे ज़्यादा आना चाहते हैं। और क्या ये अच्छी है या बुरी है, इस पर डॉक्टर अशरफ और डॉक्टर तारिक की काफ़ी अच्छी डिबेट है, तो उसमें हम देखेंगे कि ये इनमें से क्या इसके फायदे हैं, क्या नुकसान आते हैं। कुछ चीज़ें अच्छी हैं, कुछ बुरी हैं दोनों में। तो ये आप देखेंगे जो इम्पैक्ट है इसका, 2015 में हमारे पास जो बेसिक है, पंजाब में टोटल 2500 बेसिक हेल्थ यूनिट्स हैं, पाकिस्तान में 5000 बेसिक हेल्थ यूनिट्स हैं, RSC पाकिस्तान में तो तकरीबन 500 के करीब है, पंजाब में 300 हैं। तो उसमें अगर आप देखें तो जो 2000, ये पंजाब का डाटा सिर्फ क्योंकि जो सेंट्रल इलेक्शन के मार्क्स हैं ये सिर्फ पंजाब में स्टार्ट हुआ है, बाकी प्रोविंसेस में नहीं। इसमें अगर आप देखें 2015 में हमारे पास 71% पोजीशन डॉक्टर्स की फिल हो गई थी बेसिक हेल्थ यूनिट्स पे, जून 2015 का डाटा। 2016 में अगर आप देखें जून में, एक साल बाद 68%, ये तकरीबन 68-70 इसी रेंज में रहता था डाटा। लेकिन जब 17 में प्रॉपर्ली सेंट्रल इलेक्शन वाला सिस्टम इम्प्लीमेंट हो गया तो उसमें आप देखें कि 73 से एकदम 87% पे चला गया 2017 के अंदर, और उसके बाद से ये कॉन्स्टेंटली राइज होता जा रहा है। इस वक्त हमारे पास हम गारंटी के साथ कहते हैं कि आप किसी भी बेसिक हेल्थ यूनिट पर जाएँ, ये नहीं हो सकता कि आपको वहाँ पर डॉक्टर ना मिले। वहाँ डॉक्टर अवेलेबल होगा, पोस्टेड होगा, वहाँ बैठा हुआ भी होगा, क्योंकि उसकी अटेंडेंस बायोमेट्रिक है, वो काम कर रहा है या नहीं कर रहा वो एक अलग है, उसमें मैं आपको भी आगे बताता, लेकिन वो वहाँ बैठा होगा सुबह 8 बजे से लेकर 2 बजे तक वहाँ बैठेगा भी, और जो काम वो कर रहा है मैं आपको बताता हूँ। इसी तरह से अगर आप RSC को देखें जो रूरल हेल्थ सेंटर हैं, तो इसमें भी 65 70 इसी रेंज में होता था, इस वक्त हमारे पास 99% है। हमारे पास डॉक्टर्स की शॉर्टेज नहीं है। प्रॉब्लम ये है कि डॉक्टर ज़्यादा हो गए, पोजीशन हमारे पास कम है। अब जो गवर्नमेंट है उसको जो YDA की डिमांड है या PMA की डिमांड है वो ये कि आप डॉक्टर्स की सीटें बढ़ाएं, कि हमारे पास जो प्रोडक्शन है वो ज़्यादा हो गई है और रिक्वायरमेंट भी ज़्यादा है, काम भी ज़्यादा है, वर्क लोड भी ज़्यादा है, तो इसलिए आप नंबर 2 जो डॉक्टर्स हैं उनको बढ़ाएं। अब जो प्राइमरी हेल्थ केयर का हमारा स्ट्रक्चर है, बेसिक हेल्थ यूनिट RSC का, वहाँ पे काम क्या क्या होते हैं? तो बेसिक हेल्थ यूनिट्स पे क्यूरेटिव सर्विसेज हैं, प्राइमरी मतलब कि बहुत जो OPD टाइप के केसेज हैं, सिंपल जिनको आप एडमिट नहीं करना है उनकी वहाँ पे आप ट्रीटमेंट देते हैं, उनकी मेडिसिन भी गवर्नमेंट फ्री ऑफ कॉस्ट प्रोवाइड करती है। लेकिन इसके अलावा वहाँ पे बेसिक यूनिट्स पे ऑब्स्टेट्रिक सर्विसेज भी मौजूद है। हमारे पास पंजाब में 1200 बेसिक यूनिट्स हैं जो 24 आवर्स चलते हैं। वहाँ पे डॉक्टर के अलावा पैरामेडिकल स्टाफ होता है जो शाम को और रात को मौजूद होता है और डिलीवरीज कंडक्ट कराता है। एंटीनेटल सर्विसेज भी शाम को अवेलेबल होती है, इम्यूनाइजेशन सर्विसेज भी अवेलेबल होती है। इसके अलावा जो RSC हैं वहाँ पे इंडोर की फैसिलिटी भी है, 20 बेड्स होते हैं, वो यूटिलाइज नहीं होते क्योंकि वहाँ पे लोगों को इतनी अवेयरनेस नहीं है कि वहाँ पे एडमिट किया जा सकता है। वहाँ पे मेडिसिन की अवेलेबिलिटी भी उस तरह से नहीं होती है और लोगों का ट्रस्ट भी इतना ज़्यादा नहीं कि वो वहाँ जाए। हमारे लोगों का ज़्यादा ट्रस्ट होता है कि अगर एडमिट होना है तो हॉस्पिटल जाकर एडमिट हो। तो बेसिक ट्रॉमा मैनेजमेंट और इस तरह की जो छोटी मोटी इंडोर एडमिशन है, ड्रिप वगैरह लगाते हैं, वो RSC पे लगा देते हैं। इसके अलावा जो एक बहुत बड़ा रोल है हमारे सेंटर्स का बेसिक हेल्थ यूनिट और RSC का, वो प्रिवेंटिव प्रोग्राम्स के लिए। तो हमारे पास प्रिवेंटिव प्रोग्राम है जिसमें कम्युनिकेबल डिजीज प्रिवेंशन है, हेपेटाइटिस B और C का प्रोग्राम है, HIV AIDS का प्रोग्राम है, TB कंट्रोल प्रोग्राम है। ये सारे जो इनका भी इनकी सर्विसेज बेसिक हेल्थ यूनिट्स पे अवेलेबल होती हैं, लेकिन ये इन्होंने अपना स्टाफ जो पैरामेडिकल है वो वहाँ पे हायर किया होता है और उनके थ्रू सर्विसेज दी जाती है। इसी तरह से वैक्सीनेशन की सर्विसेज होती है, मेंटल हेल्थ की स्क्रीनिंग अभी रिसेंटली हमने स्टार्ट की है, उस पर डॉक्टर्स को ट्रेन भी कर रहे हैं जो अपॉइंटेड है वहाँ पे। और मैटरनल न्यूबॉर्न चाइल्ड हेल्थ और न्यूट्रिशन की सर्विस है। ये जितने भी प्रिवेंटिव प्रोग्राम हैं ये बेसिकली रिस्पॉन्सिबिलिटी डॉक्टर की है, लेकिन जो सर्विस डिलीवरी करने के लिए वहाँ पे स्टाफ मौजूद है, वो डॉक्टर के साथ असिस्ट करने के लिए स्टाफ होता है जिसमें मिडवाइफ्स हैं, LHVs हैं, वैक्सीनेटर्स हैं। ये तो सेंटर पे बैठे हुए स्टाफ है। इसके अलावा इसी बेसिक हेल्थ यूनिट से आउटरीच स्टाफ भी जाता है जो कि कम्युनिटी में लोगों के घरों तक जाके सर्विसेज देता है, जिसमें वैक्सीनेटर्स हैं जो घर घर जाके बच्चों को वैक्सीनेट करते हैं, लेडी हेल्थ वर्कर्स हैं जो बच्चों की न्यूट्रिशन की स्क्रीनिंग करती हैं, फैमिली प्लानिंग की सप्लाईज देती हैं। इसके अलावा एंटीनेटल स्क्रीनिंग भी मदर्स की करती हैं। फिर CTC सुपरवाइजर है, जैसे घरों में आके डेंगू का चेक करते हैं कि पानी खड़ा हुआ या नहीं खड़ा हुआ, मॉस्किटो लार्वा को डिटेक्ट करना, इस तरह की चीज़ें सारी देते हैं। सैनिटरी इंस्पेक्टर्स हैं, पेट्रोल है, पोलियो वर्कर है। ये सारा जो स्टाफ है ये बेसिकली रिपोर्ट कर रहा होता है उस डॉक्टर को, जो डॉक्टर उस हेल्थ फैसिलिटी का इंचार्ज है। ये जो मैं आपको पहले बात कर रहा था कि वो डॉक्टर काम कर रहा है या नहीं कर रहा, उस डॉक्टर को तो पता ही नहीं कि उसका जो स्टाफ है वो क्या काम करता है, उसको हमने कभी ट्रेन ही नहीं किया। हमारा जो डॉक्टर MBBS करके आता है उसको ये नहीं पता कि हमारा जो प्रिवेंटिव प्रोग्राम है वो क्या है, वो क्या करते हैं, कौन सा स्टाफ है उसमें, और उस स्टाफ का क्या रोल है और उस रोल में डॉक्टर का क्या रोल है। मसलन आप जैसे जो हमारा मॉडल बना हुआ है वो इस तरह से कि एक बेसिक हेल्थ यूनिट है और वो एक यूनियन काउंसिल को कवर कर रहा है 25,000 से 30,000 की पॉपुलेशन को। उस पॉपुलेशन में कोई कम्युनिकेबल डिजीज होता है, वहाँ पे कोई वैक्सीन का प्रॉब्लम होता है, वैक्सीनेशन कवरेज नहीं हो रहा, वहाँ पे कोई पोलियो का केस होता है, तो वो सारी चीज़ें हमारे डॉक्टर की रिस्पॉन्सिबिलिटी में आती हैं। लेकिन हमारा डॉक्टर जो है वो उसको नहीं देखता, क्योंकि प्रॉब्लम क्या हुआ है, वो जो हमने सेंट्रल इलेक्शन की है उसकी वजह से आप वो लोग आ गए हैं यहाँ पे सारे जो कि जाना किसी और स्पेशलाइजेशन में चाहते हैं, लेकिन नंबर लेने के लिए वो यहाँ पे आ जाते हैं। अब वो आके बेसिक हेल्थ यूनिट पे OPD वाले कमरे में बैठ जाते हैं, अंदर से कमरा लॉक होता है और वो बैठ के एग्जाम की तैयारी कर रहे हैं। और बाकी जो मरीजों को देखना है OPD जो है वो डिस्पेंसर चलाता है, और जो इसके फीमेल केसेज हैं उनको LHVs देखती है, मतलब चाहे फीमेल OPD है या एंटीनेटल केयर है कोई भी है, वो सारे LHVs देखती है, मेल पेशेंट सारे डिस्पेंसर देखता है। बच्चों को जो है वो कभी LHV देख लेती है, कभी डिस्पेंसर देख लेता है। तो जो डॉक्टर है वो वहाँ पे वो काम नहीं कर रहा। तो हमें जो इंडिकेटर जिस पे हमें दिया था, क्योंकि वो गवर्नमेंट हमारी इसी तरह से काम करती है कि लोगों ने कंप्लेन की कि हम जाते हैं वहाँ पर डॉक्टर नहीं होता, तो चीफ मिनिस्टर ने कहा कि अच्छा डॉक्टर नहीं होता तो ये सिस्टम लगा देते हैं, अटेंडेंस लगा देते हैं, डॉक्टर वहाँ मौजूद हो। अब डॉक्टर तो वहाँ मौजूद है, लेकिन उस मौजूद होने का हमें कोई फायदा नहीं है। डॉक्टर को ये जो नंबर भी ले रहा है, अपना मेरिट भी बना रहा है और चला जाता है। जिस तरह मैंने स्टार्ट में आपको बताया कि जो CPSP की हमारे पास डिग्रीज मौजूद हैं, MCPSP और FCPSP फैमिली मेडिसिन में, लेकिन इसमें इनरोलमेंट बहुत कम है। इसको इनकरेज करने के लिए CPSP ने ये भी किया कि MCPS कोई भी डॉक्टर जिसका 5 साल का एक्सपीरियंस है अपना प्राइवेट क्लिनिक चलाने का, वो भी आया रात एग्जाम दे और कुछ बेसिक उनकी ट्रेनिंग है वो पूरी करे और उसके बाद एग्जाम देके MCPS की डिग्री ले सकता है। उसके बावजूद इनरोलमेंट बहुत कम है, कुछ लोगों ने ली है डिग्री सिर्फ इसलिए कि डिग्री मिल जाए। उस डिग्री का फ़ायदा उनको इसलिए नहीं होता क्योंकि आगे कोई पोजीशन इस तरह की नहीं क्रिएटेड है कि वो उसकी अपॉइंटमेंट में उसको फ़ायदा हो, वो P2C करा होगा जिस तरह सिंपल MBBS डॉक्टर है। इसी तरह से FCPS 4 साल का प्रोग्राम भी है, लेकिन उसमें भी इनरोलमेंट हमारी बहुत ज़्यादा नहीं है। इसके छोटी छोटी ट्रेनिंग डिप्लोमा वगैरह फैमिली मेडिसिन में काफ़ी सारे इंस्टीट्यूट्स हमारे पास हैं, जिसमें फादर मेमोरियल का बहुत बड़ा नाम है। उन्होंने इसको पूरा जो इवन CPSP को भी उन्होंने बड़ा सपोर्ट किया है, जो उनका FCPS का प्रोग्राम लॉन्च करना था उसमें आवा खान के प्रोग्राम में शिफा ट्रस्ट वालों के हैं, लेकिन ये सारे प्राइवेट सेक्टर के। पब्लिक सेक्टर में हमारे पास कोई भी अच्छा फैमिली मेडिसिन का प्रोग्राम नहीं है सिवाय CPSP के। अब क्यों नहीं चलता है मॉडल? एक तो ये है कि हमारे पास गवर्नमेंट ने कभी इसकी तरफ देखा नहीं, दूसरा है कि हमारा जो रेफरल सिस्टम है वो इस तरह का नहीं है कि आपने किसी एक चैनल के थ्रू कराना है। जैसे NHS की डॉक्टर साहब ने अभी एग्जांपल दी, तो किसी ने भी अगर आपके हॉस्पिटल में जाना है रेफर होना है तो GP के थ्रू रेफर होना है। हमारे पास ये नहीं है, हमारे पास ये है कि मेरा आज दिल करता है मैं हॉस्पिटल चला जाऊँगा, मैं चला जाऊँगा, कल को मैं कहता दिन आ जाना मैं वहाँ चला जाऊँगा। कोई मुझे रोक नहीं सकता कि मैं किस हॉस्पिटल में जाऊँ। मैं लाहौर में रहता हूँ, मैं कराची के किसी हॉस्पिटल में जाकर चेक करा सकता हूँ बगैर किसी रेफरल के, बगैर किसी चीज़ के। तो और ये हर बंदे के लिए, ये नहीं है कि मैं डॉक्टर हूँ तो मैं चला जाता हूँ। कोई भी बंदा किसी के हॉस्पिटल में चला जाता है, हम उसको रोकते नहीं है। ये सिर्फ इमरजेंसी पे एप्लीकेबल नहीं है, OPD पे भी है। इंडोर वाले केसेस जो वो हम लेते हैं OPD के थ्रू, लेकिन वो उसी हॉस्पिटल के OPD के थ्रू लेते हैं। तो ये जब तक कि हम इस सिस्टम को वो इस तरह से स्ट्रीमलाइन नहीं करेंगे कि जो जिस एरिया में रहता है वो उस हॉस्पिटल के थ्रू, उसके बेसिक हेल्थ यूनिट के थ्रू, RSC के थ्रू ना आए, तब तक ये हमारा प्रॉब्लम रहेगा। और इसका रिजल्ट क्या होता है? ओवर बर्डन होता है, जो कि आप टर्शियरी हॉस्पिटल में देखते हैं कि इवन डायरिया के केसेस भी आप ट्रीट कर रहे हैं गंगाराम की इमरजेंसी में बैठ के, जो कि नहीं होनी चाहिए। अब ये अगर आप देखें पिछले 4-5 साल का एवरेज डाटा है, तो हमारे पास जो OPD है एवरेज टर्शियरी केयर हॉस्पिटल में 4000 की OPD है ऑन एवरेज डेली। ये पंजाब के जितने हॉस्पिटल हैं उनका सबका एवरेज है। डिस्ट्रिक्ट हेडक्वार्टर्स पे 2300 की OPD है पर डे, रूरल हेल्थ सेंटर्स पे 900 की है, सॉरी तहसील हेडक्वार्टर पे 900 की है, रूरल हेल्थ सेंटर पे 350 की है, बेसिक हेल्थ यूनिट पे 90 की है। अब जो बेसिक हेल्थ यूनिट पे डॉक्टर बैठा हुआ है उसे एक डॉक्टर पे 90 पेशेंट पर डे है, लेकिन वो देख नहीं रहा, देख उसके डिस्पेंसर में बाकी लोग हैं। अगर हम टोटल नंबर देखें बाय फैसिलिटी टाइप के सामने कितनी OPDs हुई हैं, तो उसमें अगर आप देखें तो सबसे बड़ा जो चार्ट है वो बेसिक हेल्थ यूनिट का है। 2,20,000 मरीज बेसिक हेल्थ यूनिट पे देखे जाते हैं हर साल। टीचिंग हॉस्पिटल में 157,000 देखे जाते हैं। ये जो नंबर बेसिक हेल्थ यूनिट का ज़्यादा है वो इसलिए कि बेसिक हेल्थ यूनिट 2,500 है, उनका नंबर ज़्यादा है। टीचिंग हॉस्पिटल हमारा 42 है, तो इसलिए आपको ये नंबर्स यहाँ कम लगेंगे, लेकिन पर डे अभी जब आप देखेंगे तो आपकी टीचिंग हॉस्पिटल की बहुत ज़्यादा है। अब हमें क्या करना चाहिए? इसमें हमने बहुत सारे मॉडल देखे हैं। NHS के मॉडल को भी हम बहुत दफ़ा कोट करते हैं कि पाकिस्तान में उस तरह का मॉडल करना चाहिए। इसके अलावा हमने इंश्योरेंस वाला जो अभी स्टार्ट किया उसमें भी अभी डिस्कशन चल रही है कि उसमें हम OPD को इंक्लूड कर दें ताकि जो जनरल प्रैक्टिशनर्स हैं उनके थ्रू हमारा बर्डन कुछ OPD का विषय हो जाए। लेकिन अभी तक जो हमारा इंश्योरेंस प्रोग्राम है वो सिर्फ इन लोगों को कैटर करता है, आउट लोग तो नहीं करता, तो जनरल प्रैक्टिस उसमें कवर नहीं होती। इसके अलावा ये जो मैंने आपको बताया कि एरिया हम डिफाइन कर देंगे, इस एरिया से बंदा है और सिर्फ वहीं से ट्रीट हो जो उसका डेजिग्नेटेड हॉस्पिटल है। इसमें भी बहुत दफ़ा बात हुई है, लेकिन ये भी करना काफ़ी चैलेंजिंग है क्योंकि हमारे पास उस तरह से बाउंड्रीज वेल डिफाइंड नहीं है लोगों की। एड्रेसेस अपडेटेड गवर्नमेंट के पास मौजूद नहीं होते, तो वो किसी तरह से उसको डिफाइन नहीं कर सकते। इसके अलावा जो फैमिली फिजिशियन की पोजीशन एग्जिस्ट नहीं करती, इनको क्रिएट करने की ज़रूरत है कि हमारा जो पब्लिक सेक्टर जो सिस्टम है उसके अंदर हम ये पोजीशंस क्रिएट कर दें। और इसका भी कोई सर्विस स्ट्रक्चर हो कि जैसे बाकी स्पेशलिटीज़ में मतलब आप पहले SR बनते हैं, फिर AD बनते हैं, एसोसिएट और फिर प्रोफेसर, तो इसमें फैमिली मेडिसिन में भी इस तरह का स्ट्रक्चर होगा तो फिर लोग अट्रैक्ट होंगे और आएंगे। जैसे आप देखें कि अभी हमारे पास एनाटॉमी फिजियोलॉजी में फिर भी लोग चले जाते हैं, फैमिली फिजिशियन वाली साइड पे नहीं आते क्योंकि इसमें ये स्ट्रक्चर ही मौजूद नहीं है। तो फैमिली फिजिशियन अगर मैं बन गया हूँ तो उसके बाद मैंने क्या करना है, उसके बाद अगर मैं प्रोफेसर बनना चाहता हूँ तो मैं नहीं बन सकता। तो जब तक ये इस तरह का स्ट्रक्चर नहीं होगा तब तक हम इसको नहीं कर इस फैसिलिटी को प्रमोट नहीं कर सकते। इसके अलावा जो MO और WMO की पोजीशन हमारे पास बेसिक हेल्थ यूनिट्स में, इसको बहुत दफ़ा रिडेजिग्नेट करने का, इसको कभी वो कहते हैं कि अच्छा इसको हेल्थ ऑफिसर कह देंगे, कभी कहते हैं कि इसको हम कम्युनिटी हेल्थ ऑफिसर कह देंगे, कोई ना कोई इस तरह के डिफरेंट नामों से इसको चलाते रहते हैं। तो जब तक हम फैमिली हेल्थ वाला मॉडल लेकर नहीं आएंगे और स्ट्रक्चर हमारे पास मौजूद है, इंफ्रास्ट्रक्चर सारा है, बेसिक हेल्थ यूनिट RSC और वहाँ से आगे फिर आप रेफर होते हैं। सिर्फ ये कि उसको आप रीडेजिग्नेट करके फैमिली फिजिशियन का दे दें और एक रिस्ट्रिक्शन लगा दें कि हॉस्पिटल डायरेक्टली मरीज नहीं जा सकता, तो ये सिस्टम थोड़ा सा शायद बेहतर हो जाए। थैंक यू।
Thank you very much, Dr. Miller. That basically shows, especially in the province of the Punjab, मेरे अबू मम्मी जो थे वो भावलपुर के फर्स्ट जनरल प्रैक्टिशनर थे। मैं अपना ये इस तरह की स्लाइड्स असल में मैं इससे मुझे याद आया था कि निज़ामी साहब भी आके इस पर अच्छी डिबेट भी करेंगे और सर डिबेट करेंगे कि उस वक्त से मैं देखता आया, मैं रिटायर हो रहा हूँ, स्लाइड वही की वही है, आप ये देख रहे हैं, आपके को भी यही स्लाइड देंगे। लगता ऐसा है
सर ये आरफाना कलाम आ गया
सर
बहुत बड़ी बात कह दी।
तो वो अब उसमें ये है कि ये कौन करेगा, कैसे करेगा, हमारे सीनियर यहाँ मौजूद हैं, शायद कुछ ना कुछ आपकी स्ट्रगल से जरूर होगा सर, लगता है ऐसा है। एंड आई विश एंड आई प्रे कि ये आरफाना कलाम जो है ये हकीकत में कन्वर्ट हो जाए। Let us now invite Professor Noreen Akmal. She would basically highlight the challenges of medical education and role of DME, Patna Medical University. Madam, इसको देखें, इसकी स्पीकर में देंगे।
वही सोच रही
I was reciting the topic challenges of medical education and role of DME, and I was thinking that the persons who become family physicians or occupational health physician, they have to undergo first the basic medical education and then they adopt that. So that is the context in which I am going to talk. I am going to divide my talk into brief history of medical education in Pakistan, and I will try to be brief and precise. Challenges faced by medical education sector in Pakistan, role of DME in medical education and the way forward. At the time of partition, when the Pakistan was created, there were only two medical colleges, we are all aware, King Edward Medical College and Law Medical College. And there was mass migration of non-Muslim doctors, so we are left with very few physicians. And there was inadequacy of health coverage, especially in the rural areas. This is the brief history that in 1948, when the Pakistan was created in 1947, Pakistan Medical Council was created, and the act which was adopted was the Indian Medical Council Act 1933. So we adopted that and we named it as the Pakistan Medical Council. This college, Fatma Jinnah Medical College, was also created, established in 1948. Then different medical institutions, they were developed in the public sector, not in the private sector. 1962 is the milestone because CPSP was created, Pakistan Medical Research Center was created, and Pakistan Medical Council was reconstituted as Pakistan Medical and Dental Council, PMDC. After this, comes the era of the private medical colleges. Two private medical colleges were established, that was Awakhan and Bakai Medical College. Then after that, and especially after the year 2000, we have seen a mushroom growth of private medical colleges in Pakistan. And multiple medical universities, they have been opened in Pakistan, and this is the situation that we have 48 public sector as compared to that 75 private sector medical colleges in Pakistan, 18 public sector dental colleges and 43 private sector dental colleges. So that shows that the private sector is now overpowering the public sector. There are 39 postgraduate medical institutes and 14 medical, it might be more than that. I was able to find the 14 medical universities in Pakistan. The changing phase of medical education at the time of partition, there were approximately 1,000 registered or properly qualified doctors. Now we have approximately more than 250,000 registered, 2.5 lakh doctors हैं हमारे पास जो registered हैं with the PMC और PMDC. वो जो भी कुछ है हमें नहीं पता, वो कभी PMDC बनती है कभी PMDC. And this
Regarding the Department of Medical Education, because I am the director of the DME, in 1974 was the time when the 3 workshops were conducted by the WHO regional training center, which was in Iran. They came here and they conducted 3 workshops on education planning in Pakistan. उसके बाद फिर DME सेटअप होना शुरू हुआ. CPSP ने अपना डिपार्टमेंट ऑफ मेडिकल एजुकेशन सेट किया एंड डिपार्टमेंट ऑफ मेडिकल, दिस डिपार्टमेंट was established in Farmajina Medical College in 1986. यहाँ पे 1986 में उस बनाया गया था. Different courses were started. Health professional education सबसे पहले CPSP took the lead and started CPSP diploma in health professional education. And then in 2008, PMDC made it mandatory that every medical college should have its own DME. अब हर कॉलेज ने DME तो बना लिया है, लेकिन their DME is not headed by a full-time medical educationist. I am not a full-time medical educationist. I have just one assistant professor who is a full-time medical educationist, and we too are running the Department of Medical Education of Farmajina Medical University. This is the situation. And after this, multiple universities, they have started Masters in Medical Education and certification program. We at Farmajina Medical University, we are also conducted certificate in health professional education. This is the picture जो inauguration हुई थी फार्माजिना मेडिकल कॉलेज में 12 अक्टूबर 1986 में, और इसकी फर्स्ट डायरेक्टर थी डॉक्टर रोज़मदान, which she was my teacher as well, डॉक्टर रोज़मदान. And this is the photograph of the first workshop which was conducted in Department of Medical Education on education planning and evaluation in 1986. Now we come to the challenges which we are facing in medical education in Pakistan. I have written a few of the challenges which we are facing in the medical education sector. सबसे important तो है कि leadership crisis in medical education. Medical education, Department of Medical Education या medical education as a subject or specialty, it's not, although it has been recognized to some extent now, there is lack of national strategies on medical education issue. बहुत ज़्यादा कमी है. Weak educational research, I am talking about the educational research, बहुत कम हो रही है. और continuing professional development, there is no structure of continuing professional development in Pakistan. Regarding the leadership, Pakistani political and healthcare leaders, they lack vision to provide a robust medical education system to the country. Current efforts to develop a medical education system responsive to the need of country, they are insufficient. इसकी एक एग्जाम्पल ये मैं देना चाहूँगी. In 1948 में पाकिस्तान मेडिकल काउंसिल बनी. 1962 में it was named Pakistan Medical and Dental Council. 2019 में गवर्नमेंट थॉट कि PMDC सही काम नहीं कर रही है, so they abolished the PMDC and they formed the Pakistan Medical Commission by the name of PMC. 2019 में PMC आ गया. 2020 में इस्लामाबाद हाई कोर्ट ने कहा नहीं जी PMC खत्म है, PMDC वापस आ जाए.
मौला जट अच्छा
ये हुआ हमारे साथ. उसके बाद जनाब सितंबर में जॉइंट सेशन ऑफ सेनेट और पार्लियामेंट ने कहा, एक बिल पास किया, तो उन्होंने कहा नहीं जी PMDC को रिप्लेस कर दें दोबारा से PMC में. और इस वक्त करंट सिचुएशन इज दैट अगस्त 2022 में सेनेट की स्टैंडिंग कमेटी ऑन हेल्थ हैज अप्रूव्ड द PMDC अमेंडमेंट बिल. सेनेट ने बिल पास कर दिया है कि PMC को खत्म कर दें और PMDC को दोबारा से आपको, लेकिन प्रेसिडेंट ने बिल पास नहीं किया, उसने साइन नहीं किया, कमेटी से पास हो गया हुआ है. लीगल स्टेटस हमारा क्या है? वी आर एट द टाइम वी आर गवर्न्ड बाय PMC और PMDC लीगली यहाँ क्या हमें नहीं मालूम. तो दिस इज द करंट सिचुएशन ऑफ मेडिकल एजुकेशन जो हमारे पॉलिसी मेकर्स हैं. तो दिस इज द प्रॉब्लम. अब आगे क्या होगा हमें नहीं पता कि हम PMC के अंडर रहेंगे या PMDC के अंडर रहेंगे. दूसरी प्रॉब्लम जो है कि वो मैंने हाईलाइट की थी कि मेडिकल एजुकेशन को एज एन एंटिटी, एज ए सब्जेक्ट, वो PMDC ने तो कह दिया कि डिपार्टमेंट ऑफ मेडिकल एजुकेशन दे शुड बी क्रिएटेड इन ईच एंड एवरी मेडिकल कॉलेज. आर दे फंक्शनल? आर दे हेडेड बाय प्रॉपर मेडिकल एजुकेशनिस्ट? आर दे परफॉर्मिंग देयर ड्यूटीज? दैट इज अ बिग क्वेश्चन मार्क हमारे सारे मेडिकल कॉलेजेस में. But in order to get themselves recognized, they have created Department of Medical Education. National strategies on medical issues, they are lacking. Strategies की मैं डिटेल में नहीं जाऊंगी क्योंकि इसमें एक पॉइंट पे we are going to take lot of further strategies related to quality of medical education regarding licensing, relicensing, accreditation, curriculum, teaching, learning, assessment. हमारे पास इसकी कोई standard policies, we don't have those standard policies. Educational research बहुत वीक है और जो एजुकेशनल रिसर्च हो भी रही है उसकी रिजल्ट्स को हम अप्लाई नहीं कर रहे. वी आर नॉट अप्लाइंग द रिजल्ट्स ऑफ दोस रिसर्च टू आवर सेटअप. दिस इज unregulated, there is no continuing professional development. In Pakistan, if I do MBBS and I am registered with the PMDC, I have the license to practice for rest of my life. अभी तक तो यही सिस्टम है. There is no revalidation, no relicensing. एक दफ़ा मैं रजिस्टर हो गई उसके बाद मुझे कुछ आता है या नहीं आता, मेरा नॉलेज अप टू डेट है या नहीं है, I have the license to practice. This should be taken care of. This is also again a big issue. बेशक जो I looked into the document of the PMDC or BMC, it has written the development of lifelong learning skills. They should be part of your teaching, but the curricular instruction and assessment practices currently in use in most of the medical colleges in Pakistan, they do not promote lifelong learning. The third part of my talk, मैंने इसको डिवाइड किया था कि एक ब्रीफ हिस्ट्री, फिर चैलेंजेस, फिर DME का क्या रोल है. DME का रोल, there are so many roles which can be assigned to DME. उनको अगर मैं लिस्ट करूं तो more than 50 roles बनाए जा सकते हैं, but ये सारे जितने भी roles which can be assigned to DME, they will depend which role to be assigned to DME depending upon the existing organizational structure, role of the existing staff, distribution of the educational functions, financial and other resources, and vision of the leadership of the institute. ये एक list है of the functions of the DME. ये जरूरी नहीं कि हर DME ये सारे function करे, but depending upon the previous factors, these roles can be assigned to the Department of Medical Education. Briefly, मैं एक दो लाइन हर रोल के बारे में बताऊंगी. Regarding curriculum development, DME का क्या रोल हो सकता है? DME can help to develop a new curriculum, it can help to implement the existing curriculum, and it can evaluate कि जो अपने curriculum है वो properly implement हो भी रहा है कि नहीं हो रहा. Similarly, DME has a role in teaching and learning. कैसे उसका रोल आता है? It can help the faculty on instructional design activities, it can help the faculty on new instructional material, and a long list in which the DME can help the faculty in teaching and learning. The role of DME in assessment. Basically, we have a very well developed department of examination department. So most of these roles, they are taken up by the examination department, but the role of DME can be that it can assist various departments to develop assessment strategies, policies, procedures and guidelines. बेशक जो MCQ बैंक है या रिजल्ट्स का रिकॉर्ड रखना या रिजल्ट अनाउंस करना, that is the responsibility of the examination department. Now the role of DME in evaluation. Evaluation में हर जगह DME को रोल असाइन किया जा सकता है. ये जितने भी मैं रोल बता रही हूँ जरूरी नहीं कि हर DME करे, मैं फिर ये बात कर रही हूँ, but they can be assigned. Curriculum evaluation, educational program evaluation, staff evaluation, educational process evaluation, the DME has a role. Similarly, this is a very important role, I think so. This is the most important, that is the faculty development. This role should be played by each and every department of medical education, and the DME should carry out faculty development workshops and activities so that the faculty would build up our faculty. And DME should assist various departments to identify their continuing professional department needs and develop strategies, policies, procedures and guidelines. Programs में जहाँ तक ताल्लुक है, we at Fatma Jinnah Medical University we are conducting certificate in health professional education. But if your department of medical education is well developed and well staffed, they can go with the masters in health professional education and even with the PhD in medical education. Role of DME in research and development, they can help and they can assist and they can guide the faculty in carrying out various research projects. Role of DME and IT. We have a separate IT department, very good functional IT department, but it needs improvement. And DME and IT, they should collaborate with each other to provide all these services for the faculty as well as for the students. Quality and accreditation services. They are again, DME should act as and ensure the quality of educational environment through educational environment monitoring system. These are the ideal circumstances in which a DME should work. That was the role of DME. Now, what is the way forward? Medical education is rapidly changing and evolving. Change तो होनी ही होनी है. Change is inevitable. लेकिन ये depend करेगा कि हम उस change पे कैसे response दे रहे हैं. So I am going to discuss few changes or few challenges in medical education which we as a medical educationist we should act upon. Like nowadays, वो पुराना ज़माना था कि डॉक्टर साहब ने जो कह दिया बस वो उर्फ़ आखिर है जो कह दिया डॉक्टर साहब. अब वो डॉक्टर साहब नहीं रहे. नहीं, it's a client and वो वाली situation हमारे यहाँ भी आ गई है क्योंकि लोग जो हैं they are very well informed, they have access to social media. और जब वो हमारे पास आते हैं वो पढ़ के आते हैं वो information जैसी भी हो they have some background knowledge. So accountability हमारी बढ़ गई है. तो इसका action हमारे पास क्या होना चाहिए? हमें अपनी teaching strategies को change करना है और हमें patient centered education and evidence based medicine की बात करनी चाहिए जो कि developed world कर रही है. हमें भी उसकी तरफ आना चाहिए. वही वाली बात जो मैं कह रही थी कि अब डॉक्टर का सोसाइटी से एक सोशल कॉन्ट्रैक्ट है. डॉक्टर सर्विस प्रोवाइडर है और जो पेशेंट आ रहा है वो क्लाइंट है उसके पास. हमें डॉक्टर्स जो वहाँ पे बैठे उन्हें सर्विस प्रोवाइड कर रहे हैं उनकी हमें एक्शन जो हमारे ये होने चाहिए कि लाइसेंसिंग री-लाइसेंसिंग होनी चाहिए, री-वैलिडेशन होनी चाहिए. ऐसा भी हमारे पास कुछ नहीं हो रहा. हमें अपनी असेसमेंट टेक्निक्स को चेंज करना चाहिए. वर्क प्लेस बेस्ड असेसमेंट पे आना चाहिए कि द प्रोडक्ट विच वी आर प्रोड्यूसिंग वो सोसाइटी की नीड्स को पूरा करे. पेशेंट सेफ्टी इज अ वेरी इंपॉर्टेंट कंसर्न. डेवलप्ड वर्ल्ड में इसमें बहुत है. नाउ वी आर आल्सो टॉकिंग अबाउट द पेशेंट सेफ्टी. द एक्शन विच वी शुड टेक we should move more towards the simulation, mannequins and role plays while teaching the medical students. Similarly, जो today's student, जो आजकल का student है, वो digital student है. वो पुराने ज़माने का student नहीं है. वो information, what I am saying, you can get the information from the internet. We should move towards the e-learning option, and we should use social networking in medical education in order to fulfill the demands of the digital student. Similarly, medical errors and conflicts of interest, they are being reported very frequently nowadays. What we should do, we should teach our medical student medical professionalism and ethics in more detail. हम सिर्फ थर्ड ईयर में पढ़ाते हैं behavioral sciences में, इसमें very small portion है I think ethics and professionalism. It should be given more time both in undergraduate and postgraduate medical education. This is the excuse which we take. जब हमें कहा जाता है कि modular system, you should bring the modular system, you should bring PBL or different type of teaching. We said we are short of staff, we are short of skilled teachers. The action we can take, we should, Department of Medical Education and the subject specialists, they should produce study guides for the students. We can provide them with a virtual learning environment and we can also provide them with a distance learning facilities. Change is inevitable. Change होनी है. PMDC ये कहता है या PMC ये कहता है कि जो पाकिस्तान का मेडिकल ग्रेजुएट is a 7-star doctor and he should be skillful, he should be knowledgeable, he should be community health promoter, critical thinker, professional, scholar, leader and role model. Are we producing such a doctor? ہمارے ڈاکٹر اپنے رائٹس کے لیے سڑک پہ احتجاج کر رہے ہوتے ہیں. they are found on the roads fighting for their rights. So this is the time for action. And if the change is not well directed and controlled, the political and the healthcare leadership of Pakistan should be held responsible.
Now this is the time.
Healthcare leaders hum hain, political Islamabad mein baithe hain. So that is what I have to say, and I have kept my talk very brief and precise. Thank you so much.
Thank you very much. बात नहीं आज पाना कलाम भी खत्म हुई. These things on which we are debating into the curricula and enforce them. Now we are coming to the basically the climax, and the climax is by our two very senior personnel sitting here. ये जितने भी हम ये कानून पढ़ रहे थे, ये सब किसी न किसी तौर पे इनके हाथों से इनके सामने से गुजरे हुए हैं और इन्होंने देखे हुए हैं practically basically gone through all these things, pros, cons, keep on advising the people at the helm of the affair, the regulatory bodies, और इनकी वजह से काफ़ी कुछ कंट्रोल रहता भी है और कंट्रोल होता भी है. ये जो अगला पोर्शन है ये बेसिकली नाउ वी आर running short of time, but what we are doing is that there is a debate about जो अभी हमारे नईम साहब बता के गए हैं कि BHU में डॉक्टर तो होता है लेकिन करता नहीं है कुछ, और वो कमरा लॉक करके अंदर बैठा हुआ है और वो प्रिपेयरिंग फॉर एग्जाम एंड जस्ट अर्निंग द मार्क्स. इसका क्या है? लर्नेड स्पीकर्स मौजूद हैं यहाँ पर. दे आर नॉट ओनली स्पीकर्स बट दे आर एक्सपीरियंस्ड पर्सन्स. मैं ये करूँगा कि there were two portion of this particular session. एक था पहले हमने डिबेट करनी थी और फिर उसका रिबटल करना था. I would request them कि पहले तारिक गोहर साहब सपोर्ट में BHU का they should be privatized or not privatized. गौर साहब आप हमें उसके लिए डिबेट करें, आप हमें बताएं कि प्राइवेटाइज करना है. आप फॉर करेंगे कि प्राइवेटाइज करना है. अगर प्राइवेटाइज करना है तो उसके क्या फ़ायदे क्या नुकसान होंगे, हो सकता है नहीं हो सकता, ये आरफाना कलाम मौजूद है. अगली बात ये है कि मैं ये चाहूँगा कि सर आपने जो भी अपनी पॉइंट्स देने हो आप इसमें ज़रूर दीजिएगा और फिर हम निज़ामी साहब से डिस्कस करेंगे कि वो प्राइवेटाइज करवाना चाहते हैं या नहीं करवाना चाहते, और अगर नहीं करवाना चाहते तो क्यों नहीं करवाना चाहते, उसका रिबटल भी सर साथ ही कर देंगे ताकि ये सेशन शॉर्ट हो जाए. तो जैसे कि फिर दोबारा से हम उसको देखें जवाब को. तो व्हाट वी आर गोइंग टू डू इज, मैं गोहर साहब के बारे में बता दूं. गोहर साहब जैसे मैंने पहले बताया था, यहाँ BHU में सर ने बहुत ज़्यादा काम किया. फिर ये बाहर चले गए, बाहर इन्होंने रेजिडेंसी की, फिर उन्होंने दोनों सिस्टम, रिफाइंड सिस्टम, स्पेशलिस्ट सिस्टम देखे, फिर वहाँ से दोबारा GP सिस्टम में चले गए. वहाँ के GP सिस्टम में काम किया उन्होंने, यहाँ का GP सिस्टम, वहाँ का GP सिस्टम देखा हुआ भी है, एक्सपीरियंस भी किया हुआ है और आज सुन भी लिया है. तो अब देखते हैं कि सर हमें क्या मशवरा देते हैं. आइए.
चेयरमैन की इजाज़त से अगर आप गुस्ताखी ना समझें तो मैं थोड़ी सी इसकी बैकग्राउंड बताना चाहता हूँ. पिछले 5 साल से ये यूनिवर्सल हेल्थ केयर प्रोग्राम कर रहे हैं, 3 साल से डिबेट कर रहे हैं. जो पिछली 2 डिबेट्स हुई थी उसमें निज़ामी साहब शामिल थे और इनके दो जो मुकाबले थे वो फैसल साहब थे और अरशद तकी साहब थे जो PMC के, जिनका के अपना खला भी जिक्र खैर वाला चेंज डायरेक्टली. तो हमारा जो सबसे अच्छा और सबसे पॉपुलर जो था कंपोनेंट हमारे सेमिनार का वो ये डिबेट थी, क्योंकि इसमें कुछ इमोशनल और कुछ इमोटिव इन्वॉल्वमेंट होती है, बाज़ दफ़ा कुछ स्पार्क्स भी निकलते हैं और आखिर में वोटिंग होती है. तो अगर हम इसको थोड़ा करना चाहें तो इसका अगर आप दौरानिया काम करना चाहें तो मैं ख्याल उसका अच्छा तरीका ये है कि प्राइवेट साहब 15 मिनट करते हैं अपनी जो प्रोपोजिशन को और उसके जवाब को निज़ामी साहब 15 मिनट करते हैं और उसके बाद हम 10-10 मिनट की रिबटल्स करते हैं और आखिर में वोटिंग होगी और ये आप लोग बताएंगे कि इसको प्राइवेटाइज करना चाहिए. तो मेरा ख्याल है हमारे पास इस तरीके से तकरीबन 50 मिनट्स हो जाएंगे. इसके बाद एक मीटिंग है जो कि आप सब लोग इन्वाइटेड हैं, जिसमें कि ऑडिटोरियम में 11:40 पे जो कि कोविड क्वेश्चन टाइम है. तो अगर तारिक और साहब तैयार हैं तो आप तशरीफ रखें.
मौका दें. Okay, I'm giving this talk. Partially helpful, really. I think quite a few of the things which I was going to say, they have already been taken, so I will kind of move over them. A brief, I think, background, everybody has told me about it, and probably will reinforce that a little bit. My first job was in a basic health unit, and it was exactly my experience looks like changed at all, and that was 34 years ago. My first day there was, then my dispenser there said, Dr. Saab, you are going to do something else, I think, so you don't need to be here. You can go back to Lahore. I will bring your salary there and maybe something from here as well. And then that's all you need to do. And that was the uphill task which I had there. And that, I think, partly encouraged me to go to UK, where I did surgical training, nearly finished it, and then thank goodness I jumped the ship, moved over to general practice. Two surgeons in a family were a bit too much, and I think I made the right decision, and I still feel that my wife is worse off than I am. I've been working for the last 22 years in general practice. It's an average size general practice, about 10,000 patients, but we have got about staff of about 50 people, which we manage. I am also director of a local GP federation, which looks after about 15 local practices. Then I am also training other GPs in the local degree, and also some medical students from neighbouring universities of Leicester and Nottingham. So kind of a broad experience like that gives me, I think, some idea about talking about this topic. Now, I thought I will briefly kind of talk about just development of NHS in UK, then kind of what role primary care plays in it, and then financial woes of Pakistan. I think that is a main issue here, and how its implications on their health. And then lastly, I think it takes me up to what I think would be a way forward for Pakistan. Now, NHS started in 1948 in the wake of World War II. It was started with the Labour government. It was based on three main principles. That everybody will be provided a good quality care, and it will be based on their clinical needs, not their ability to pay, and it will remain free at the point of delivery. And NHS has gone through lots of things through last 74 years, and they have stuck with those three guiding principles. They haven't really compromised on that. NHS basically funded, 99% funded by taxpayers' money. Only 1% comes from patient fee. In that, main role of the GP is that as compared to the normal NHS doctors, GPs are independent contractors. They are self-employed. They run it like a business, and though most part of their income comes from the NHS, about 80 to 90% depending upon which kind of a practice is that. There is a lot of flexibility in the way they operate. Everybody needs to be registered with a GP in UK to access any medical service. Patients do have a choice of choosing their GP, and they can change their choices as well. So GPs are under pressure to keep their patients happy, and that is a kind of a built-in accountability in that mechanism. GPs have to follow a core contract with the NHS, but they can negotiate additional contracts with them. COVID-19 probably is the recent example where GPs were at the forefront of providing COVID vaccination at an accelerated rate. Another job of the GP, which is an important job, is to work as a gatekeepers to the secondary and tertiary care. They provide the referrals, and it is mandatory almost. You can't get the get to be seen in secondary care without GPs referral. And another very important one, which I think they excel in that really, is to keep a complete and comprehensive electronic record of the patient. From the day they are born to the day they die, everything which happens to them medically is with their GP, and GP really closely protect it and guard it like a straight secret. I think Zainab has talked about it in detail. I don't have to delve into that anymore. My area is this really, the money. Where are we? Why we are suffering so much? And I think keep on harping on about it. I'm taking only two examples which are a common one. It's a blessed IMF data. It's a pre-COVID data. So and I think that is a pertinent one, because after COVID, lots of things are artificial really, they're not relevant to us. United States is ranking 11th in GDP per capita, about $59,000 plus. United Kingdom is at 26 with 43 plus, while Pakistan is languishing at 135 in ranking. It's probably slipped further down now, with a GDP of 5,000 plus. More interesting is this next slide, that United States, with a massive resources, still devotes the most out of about 17.8% of their GDP on their health. United Kingdom 10.5%, which is in par with the rest of the European countries, more or less the same. And Pakistan, with its meager GDP, then allocates a puny 3.3% of their GDP on health. And out of that, I don't have the figures, it is probably even smaller percentage which goes to the primary care, where I think main action happens. In fact, that is something which I think Zainab mentioned that before. I'm going to underline that again, because that is an important point to think about. Out of that budget which UK has, only 10% of that budget goes to the primary care, while 90% of the medical related activity happens in primary care. So primary care is the most cost effective part of the NHS. And that is why my driving point really is, if we have got a little money, then spending that money in primary care gets you more bangs for your bucks. And that is a point I think I would like to undermine. Now, this is data from Commonwealth Fund, and it is 11 countries. UK is performing well among sort of top 5 countries in this cluster. Most of these countries there is little to choose between them. They are morely jumped together. One country stands out, which is US, which is spending the most and probably getting the least from the performance point of view. Probably not the best system to follow, I think. I've chosen one of the parameters they have taken, which is the affordability, I think, which is quite important from our point of view. And UK is the most affordable system out of the developed countries. US is obviously the most expensive one out of them. Now, that brings me to the current situation here. Now, as people were talking about before, why people are being forced to go into the basic health unit. But they are being forced into it, because basic health unit is seen only as a transition. It is not a career choice for anybody. Job is considered as a sacrifice. It's a torture really, literally. It is not an achievement. There is a general lack of motivation. There is a very low morale in these people. And that leads to absolutely appalling performance. We are not producing any results really there. And this needs to be changed. Clearly, there needs to be a change. Change needs to be everywhere, but in this area where change can be quite significant, make a significant difference. And the proposal which I have got for people from long experience is that we let GPs own those basic health units. That means that they will have a stake in it. Also, it will release significant amount of money to the health system, which should be ring-fenced for the primary care. Now, there could be details, there could be various other ways of doing it, but giving GPs actually a stake, that they have got actually a sense of belonging. GPs are then given a sure capitation fee and possibly rent, that's the way we work there, to give them a kind of financial security. So they have got a basic level of income there. Patient don't pay there, like they don't there, but they should be allowed to choose their own GP. That obviously puts pressure on the GPs to keep their patients and then try to deal with them better, because patients can switch their GP anytime. So this leads to obviously internal competition, which should be a healthy competition, which is there, very healthy competition, and then obviously internal accountability. And then external regulatory bodies can, like Care Quality Commission, can oversee the quality of overall service delivery. Now this is something, I don't know, it will need to start from there because that's an important part of it, which is that the GP should really have the ability to refer to the secondary care. That is where the gatekeeping role comes in. That is where they shift the wheat from chaff and then send the more complicated and appropriate patients to the secondary care, which is considered to be an expensive part of the system, and then deal with more common, simple problems at their level. And that can only happen by structured training of the GP. It can't probably be as elaborate to start off with. It never started as that in UK either. When I came in, it wasn't as elaborate as it is now. So they have even gone through evolution. They need to start here from probably a simpler level, telling them probably those kind of various, how to follow various clinical pathways which are more cost efficient and things like that, and then preparing them to for this role, and that kind of administrative type of role, preparing them for that. And then that will be kind of my main kind of outline of the plan. Now in summary, I will need to kind of it's a foregone conclusion. Pakistan has got limited resources. There is no question about it. And also, I think I have shown you that UK has got one of the most cost-effective healthcare systems. Not the most expensive, it's the most cost-effective healthcare system in the developed world. Primary care setup makes the backbone of that system. There is no question about it. And developing primary care in Pakistan on those lines, I think is the best way forward. And this, I wouldn't call it quite the privatization, it's a qualified privatization. There is the term which I'm coining really, which because it's not like you're selling it off your assets to anybody, is the best use of our limited resources. And I think that is, well, I am before time because I think that's where I am.
13 minutes, which is fantastic. I think now, so the point I think Tariq has made is that the BHUs should be owned by the GPs, but the patient should not pay. The government should pay the GPs to treat the patients per capita. So you register a patient, you get a fee per year. So that is the way it works in the UK. So now I will invite Ashraf Tilak sahab. इससे पहले आपने से कितने लोगों ने BHU में काम किया है? और इसमें तो क्या आप लोगों का एक्सपीरियंस है? कितने लोग हैं जिनको करना पड़ेगा इससे पहले कि आपको सेंट्रल इंडक्शन में आना? सब लोग। तो आपके इंटरेस्ट में आएगा। तो निजामी साहब
For your patients, अभी आपकी प्रिंसिपल नहीं है, लिहाजा आप हंस खेल के भी बात कर सकते हैं। अभी जब मेरे दोस्त बात कर रहे थे कि MBBS कर लिया और फिर उसके बाद क्या करेंगे, तो मुझे एक याद आ रहा था बेनजीर भुट्टो किसी एयरपोर्ट पे एक ज़माना था, आई डोंट नो वेदर यू हैव सीन इट और नॉट, कल्चर ही वो ख़त्म हो गया कि बड़े प्यारे प्यारे खूबसूरत से बच्चे वो फूल पेश किया करते, तो बड़ा ज़िमनन सा होता है। बेनजीर भुट्टो ने पूछा कि बड़े होकर क्या बनो, क्या करोगे, बड़े होकर क्या करोगे। वो मासूम सा बच्चा था मेरे जैसा, उसने कहा जी बड़ा होकर शादी करो। सो ये पाकिस्तान के अंदर गौर साहब ये जो हमारे है हालात के अंदर शादी इज वन ऑफ द इशू, करना फिर कैसे करना और फिर शादी के साथ सारा बर्ताव करना, दैट इज वन ऑफ द इश्यूज जो कि BHU से भी बढ़ के हमारे साथ है। I will not go in certain things. एक चीज जो हमारे दोस्तों ने कही, नईम साहब ने भी की, बाकी दोस्तों ने भी की, BHU गौहर साहब ने भी किया, हमारी प्रिंसिपल साहबा और अकमल ने भी ये बातें जो की, that is I want to make one thing कि patient is the prime, मरीज है जिसके लिए सारी चीजें घूमती हैं, and secondly मेडिकल एजुकेशन ने जो हमें सिखाया, जो हमें बताया कि हम मजदूर नहीं हैं, डॉक्टर we are neither workers nor managers, we are the leaders. अभी बता रहे थे ना 7 स्टार डॉक्टर्स का जो किया है, I'm sure कि अगर आपके साथ although it is मतलब 7 स्टार 3 स्टार 5 स्टार ये अजीब सी बातें लगती हैं, लेकिन जब मेडिकल एजुकेशन से they try to 3 स्टार निकला, फिर 5 स्टार कर दिया, फिर 7 स्टार कर दिया, sometime will come they will go for the 10 stars and so on. मेरे नजदीक ये चीजें एक अच्छी डिबेट है इन अ वे, गो के पिंचिंग भी है। NHS के बारे में आप लोग का I never go in debate, I discuss, I never argue. मेरी जिंदगी के लिए मकसद और मैं जिंदगी इसी तरह ही गुजारता हूँ कि दोस्तों के दरमियान हम डिस्कस करते हैं, आर्गू नहीं करते। लेकिन गौहर साहब ने जो कहा NHS के साथ के NHS के बनने की वजह थी जो सेकेंड वर्ल्ड वॉर के बाद कि जिंदगी एक ही है, whether it is in UK, whether it is in Pakistan, it is in Africa, wherever it is, life is life. और जिंदगी के साथ हमने यकीनी तौर पे वैसे ही गुजरना है जैसे कि वो हमें डिक्टेट भी करती है बदकिस्मती से। तो एक तो ये जो रखा गया टॉपिक, इसको आगे कैसे करेंगे ये ओके, थैंक यू। एक तो ये कहा गया कि BHU शुड बी प्राइवेटाइज्ड। मैं समझता हूँ कि अगर थोड़ा सा इसको कर लेते कि अगर करना है जैसे मतलब ताज साहब ने कहा, तो साहब ने कि we have to share and speak about होना है या नहीं होना, should be privatized. Meanwhile we discuss. हम कोई डिक्टेशन नहीं दे रहे, हम किसी भी बड़ी सरकार से अमेरिका, और ये कल्चर हो गया हमारा, चूंकि बरतानिया में करते हैं and we never put question, क्योंकि बड़ी सरकार ने कहा तो ज्यादा ऐसे ही होगा, so we never think of what is happening what are. मैं चूंकि इत्तेफाक से मतलब उनके साथ भी एग्री कि हमारे साथ जो मैंने आपसे कहा कि हेल्थ डिलीवरी सिस्टम के कोई ना कोई गोल्स हैं, और गोल्स बड़े मुतय्यन हैं, वेरी सिंपल, जो भी स्टेट करती है, द स्टेट्स हु आर कंसर्न्ड अबाउट द हेल्थ डिलीवरी सिस्टम, हु आर कंसर्न्ड अबाउट द पीपल, अबाउट द मासेस ऑफ देयर कंट्री, दे आर, तो हेल्थ डिलीवरी सिस्टम के जो गोल्स मुतय्यन किए गए, दैट इज द प्रिवेंट डिजीज एंड इम्प्रूव क्वालिटी ऑफ लाइफ। इट इज नॉट अबाउट डिजीज, इट इज अबाउट द क्वालिटी ऑफ लाइफ। उसके खातिर WHO हम समझते हैं उन्होंने भी 3 चीजें कर दी कि हेल्थ ऑफ पॉपुलेशन को इम्प्रूव कर रहे हैं और रिस्पांसिबिलिटीज को बेहतर करना, और फाइनेंस, जिसके ऊपर मेरे दोस्त गौर साहब तस्करा कर रहे थे कि दैट इज द मेन इशू, वेयरएज के वो जरूरी जरूर है लेकिन सब कुछ ही वो नहीं है मेरे नजदीक। कैसा है हेल्थ प्रोवाइडर्स की खातिर इंपॉर्टेंट जो चीज हमें समझने की है कि these are the public representative, जिनको हम पसंद करते हैं या नहीं करते whatsoever, but it is their primary job जिसको समझना चाहिए। State is through the government जो उनके साथ हम चुनते हैं, और health professionals जो हम आपके साथ हैं, और हमारे साथ nurses भी हैं, allied health workers भी हैं, और administration जो local administration hospitals और university के साथ होती है, और social workers को मैं समझता हूँ कि they are also one of the health providers जो कि हमारे साथ। एक चीज जो मैं मतलब बहुत मानता हूँ, with all my due respect to all my colleagues from the developed country like Britain, कि health is a right, it is not a privilege, it is a basic right, that is what we have to understand. और health professionals के साथ जो responsibilities समझी जाती हैं कि क्या होनी चाहिए, that is मतलब ये आम हम लोग समझते हैं कि punctuality होनी चाहिए, वो जैसे भी मतलब डॉक्टर साहब बता रहे थे कि बंदा बैठना चाहिए डॉक्टर, और वो डॉक्टर बैठा हुआ है और बस ठीक है जी डॉक्टर साहब बैठे हैं, पंक्चुअलिटी, बट वेदर इज इट ऑल जो उसके साथ पूरा हो जाए. एक्सेप्टेबल एटीट्यूड एंड बिहेवियर, ये हमारे लिए इम्पोर्टेंट है, जो हेल्थ प्रोफेशनल्स की रिस्पॉन्सिबिलिटीज के अंदर आता है. और मैडम तशरीफ ले आई हैं तो इनका 7 स्टार डॉक्टर भी यही कुछ सारी बातें करते हैं. सर्विस विदाउट डिस्क्रिमिनेशन एंड बायस, ये हम समझते हैं कि उसके साथ हो. एप्लीकेशन ऑफ नॉलेज एंड एक्सपीरियंस एक्सपेक्ट किया जाता है. नो फाइनेंशियल गेन्स ऑन द एक्सपेंस ऑफ पेशेंट. मेरे चाचा जी की लेबोरेटरी है और मैं टेस्ट लिख दूंगा तो मी बाई आई विल गेट थ्रू माय चाचास, अगर नहीं डायरेक्टली, ऑल्दो कि अनफॉर्चुनेटली डायरेक्टली उसके सारी चीजें आती हैं. जी सर, मैं एक स्लाइड के ऊपर मेरा है वो मैं थोड़ा सा करता हूँ. नॉलेज, skills or attitude, these are the 3 words which are the base of the medical education or so on. ये है health professional rights के. These are the basic rights. हम job security चाहते हैं, health care चाहते हैं, professional जो हमारी progression है वो चाहते हैं, adequate salary structure चाहते हैं. लेकिन मेरे पहले 3 मिनट निकाल दीजिए क्योंकि तो हम तंबीह कर रहे थे वैसे ही. फैमिली केयर चाहते हैं हमारी, जबकि अल्लाह करेगा आप लोगों की जब आएगी. और पोस्ट रिटायरमेंट केयर, हमारी उम्र में जब बुजुर्ग होंगे तो दैट्स व्हाट वी डू. पीपल्स राइट, लोगों के भी हकूक है हमारे ऊपर. लोगों के हकूक क्या है? वही है जो हमारे एज हेल्थ प्रोफेशनल, दीज आर द बेसिक राइट्स. बट दे वांट सेल्फ रिस्पेक्ट एंड एस्टीम. लाइकवाइज वी एज अ डॉक्टर वी वांट राइट टू हेल्थ. हर एक का बुनियादी हक है जिसके ऊपर आई होप दैट वी आर एग्री अपॉन. हेल्थ विदाउट डिस्क्रिमिनेशन, ये एक बेसिक राइट्स हैं जो कि लोग जो हमसे समझते हैं वो चाहते हैं. स्टेक होल्डर्स जो है इन हेल्थ डिलीवरी सिस्टम, दैट इज द स्टेट, हेल्थ प्रोवाइडर्स, वी द डॉक्टर्स और पब्लिक एट लार्ज. अब क्वेश्चन है व्हाट डज द पेशेंट वांट. ये मैंने लिखे थे जरा, मतलब जो अवामुल नास के साथ है, एंड इंटरव्यू कि मरीज क्या चाहता है. मैं चूंकि टाइम की बंदिश है लिहाजा के साथ है, और आप भी सब जानते हैं कि मरीज क्या चाहता है, और हम भी किसी तरीके से कभी ना कभी तो मरीज रही हैं. मरीज क्या चाहता है, ये लंबी चौड़ी, और जो उन्होंने कहा मैंने वैसे उसकी अंग्रेजी करके बस लिखा, इसके अंदर मेरा कोई कुछ नहीं था. बट आई विल नॉट स्पीक अबाउट इट. डॉक्टर भी चाहता है कुछ ना कुछ. डॉक्टर क्या क्या चाहता है वो मैंने आपके साथ टेंटेटिव बातें कर ली थी, लेकिन आई विल नॉट गो इन डिटेल, हेंस वी नो ईच अदर कि हम लोग क्या चाहते हैं एज अ डॉक्टर. लेकिन इसके अंदर एक चीज के साथ है कि डॉक्टर जो चाहता है, डोंट हैव अ कल्चर ऑफ फियर, बुलिंग एंड हरासमेंट. ये यूके में भी यही चाहते हैं. जो ब्रिटिश मेडिकल एसोसिएशन है वो भी यही चाहती है. हर दुनिया का डॉक्टर यही चाहेगा कि मैं अगर इज्जत नहीं तो बेइज्जत जरूर नहीं होना चाहूंगा. दिस इज व्हाट इज द बेसिक फॉर अस. और उसके साथ ही है डॉक्टर्स क्या चाहते हैं, ये अल्लाह के फजल से कुछ इसमें पिंचिंग की है, लेकिन मैं इसमें नहीं, चूंकि हमारा चूंकि डिबेट का हिस्सा है तो मैं, और मुझे अदर साहब बार बार मोबाइल भी दिखा रहे हैं कि टाइम आपका चल रहा है. अभी तो वो मेरी बच्ची 3 मिनट बाद किधर चली गई, मुझे आगे दिखाई. अब गवर्नमेंट क्या चाहती है? गवर्नमेंट चाहती है जी कि पेशेंट की सेटिस्फेक्शन हो. ये हमने भी चाहा है एज ए डॉक्टर्स, मरीज ने भी चाहा कि उसकी सेटिस्फेक्शन हो. परफॉर्मेंस अवार्ड चाहती है गवर्नमेंट. जैसे भी मेरे दोस्त बता रहे थे, गवर्नमेंट का पर्सपेक्टिव भी था कि गवर्नमेंट ने ये किया, 1917 में ऐसे किया, 2017 में ये किया, और हमने सोचा कि हम नया मॉडल क्यों ना लें, और हमारी कितनी बड़ी एप्रिसिएशन होगी कि आज BHUs खाली नहीं है. दिस इज व्हाट इज द गवर्नमेंट. वहाँ इलाज होता है नहीं होता, मतलब सॉरी लेकिन पंजाबी में देखा को, लेकिन दैट इज देयर कि हमने अपनी जिम्मेदारी पूरी कर दी, अल्लाह ना करे सब. हाई परफॉर्मेंस अवार्ड चाहते हैं. रेगुलेटरी अथॉरिटीज़म चाहते हैं. द ब्यूरोक्रेटिक ऑफिशियल प्रोटोकॉल्स. अभी यहाँ पे अगर कोई आ जाएगा सेक्रेटरी, डिप्टी सेक्रेटरी, और पता नहीं हॉस्पिटल का इंसिडेंट कि डिप्टी सेक्रेटरी आई एक खातून और उसको प्रोटोकॉल ही मिला जहाँ से MS वाज सस्पेंडेड. तो ये एक गवर्नमेंट के एटीट्यूड्स हमारे साथ रवैये रहते हैं, और शायद दुरुस्त भी होते होंगे. appropriate यूज ऑफ फंड्स. लेकिन इसके अंदर बड़ी इंटरेस्टिंग थी कि लो फंड्स लेकिन हाई रिजल्ट्स. फंडिंग थोड़ी लेकिन रिजल्ट्स उसके बड़े अच्छे चाहती है कि हुकूमत बस, मतलब इट शुड बी लाइक अमेरिका या बरतानिया या ऐसे करके वही सारी चीजें आनी चाहिए, और हम उनसे कोई डिमांड ना करें. neither the health professionals nor the health establishments. ये हमारी सरकार के साथ कोई ये ना पूछे कि ये गवर्नमेंट ये चाहती है. अब क्वेश्चन है मेरे अजीजों कि जो हमारे 3 स्टेक होल्डर जो हमने समझा, पब्लिक, गवर्नमेंट और हम हेल्थ प्रोफेशनल्स, जो आज यहाँ चीजें मौजूद हैं, क्या इन तीनों में से कोई भी सेटिस्फाइड है? नो. देयर इज नन. वेरी राइट. कोई भी इससे मुतमईन नहीं है. कि ये जो सूरत हाल चल रही है उससे मुतमईन नहीं है। अब क्वेश्चन है कि करना क्या चाहिए, व्हाट शुड बी डन। उसकी खातिर तो एक है कि अमेरिका में ये हुआ था लिहाजा ये कर दो, बरतानिया में ये हुआ था वो, तो रूस देखो कैसा मुल्क था, लेकिन रूस के अंदर ऐसी ऐसी चीजें हुई और वहाँ जो दुनिया के 191 में से 130 के ऊपर चला गया था, रशिया ने फिर वो सोवियत यूनियन टूट गया, तो ऐसे करके दैट इज द वन वे कि दुनिया ने किया, दुनिया से हमने उठाया और फिर उसके साथ हमने यहाँ पे वो चीजें कर, दैट इज वन। और उसको कहते हैं पब्लिक चला ले, उसको बेहतर कर लो, क्यूबन मॉडल है उसको ले आओ, प्राइवेट कर दो, पब्लिक प्राइवेट पार्टनरशिप ले, और एट लार्ज ये कहते हैं कि सेल आउट द सिस्टम बेच दो। आजकल वो नहीं आती टीवी के ऊपर एक आती है कि बेच दे, सो दैट इज वेरी सिंपल कि जी मैंने तो बेच दिया, तो डू इट, मतलब ये करते हैं। लेकिन एक मैं आपके साथ स्टोरी ऑफ सिविलाइजेशन, मैं बाकी एक ही मेरी स्लाइड हुई है जो आगे जो भी आएगी, कि दिस इज वेरी मच इंपॉर्टेंट, यू आर द यूथ एंड यू हैव टू अंडरस्टैंड। जैसे मैडम नौरी ने कहा था कि मेडिकल एजुकेशन को समझना जरूरी है, ये भी बड़ा जरूरी है। दैट इज द कॉलोनियलिज्म एंड इंपीरियलिज्म। ये खित्ता जिसके अंदर हम बैठे हैं 1600-1700 के अंदर दुनिया का जो था 27% प्रोवाइडर इकोनॉमिक जो था, जो जीडीपी और सारी चीजें, और जब ये हमें तरक्की करवा के हमारा गोरा बादशाह जहां से गया 1947 के अंदर, तो वो जो कंट्रीब्यूशन था दैट वाज टर्न टू 3%। नीचे चले गए हम दुनिया के अंदर वो काम करते, जिसके लिए हम जहां से हम मॉडल्स लेके आना चाहते हैं, दैट मॉडल इज बेस्ड ऑन एक्सप्लॉयटेशन, और उसके साथ वो सारी चीजें जो आगे लेके आती हैं। और इसके लिए मतलब मेरे दोस्त जो आए हुए हैं ब्रिटेन से, इंडियन मतलब हिस्ट्री के ऊपर जो सिविलाइजेशन के ऊपर ब्रिटिश लाइब्रेरीज आर मतलब फुल ऑफ ऑल। जी सर, जस्ट मेरा एक रिलैक्स, मेरी एक सिर्फ स्लाइड है, ये वो स्लाइड है जो मैं पहले कह चुका हूं आपके साथ, जस्ट गो थ्रू कि जॉब सिक्योरिटीज प्राइवेटाइजेशन, ये सर्दी है तो बनती होती है,
ये हमने ऐसा देख कर रखा हुआ है, ये आफ्टर रिकॉर्ड तरीके है, जब पर्ची ना मिलेंगे तो
कहते हैं चल जाए,
लेकिन ये भी पूरा करेंगे आज हम पूरा करते हैं। जी सर,
एक स्लाइड
नहीं ये बड़ी अच्छा
बेसिकली एक ही थी, बाकी तो ऐसे मैंने एक होता है ना वो शायद आदमी को मिल जाए कोई ना कोई, तो वो फिर उससे अल्लाह ही बचाए। सो दिस इज व्हाट इज, हमने 3 कंपोनेंट्स किए, डॉक्टर, पेशेंट, गवर्नमेंट। अगर खुदा न खास्ता जैसे एमटीआई हमारे साथ आया, हमने रोला डाल के उसको चलो रोक लिया, गवर्निंग बोर्ड्स बन गए, इधर भी अल्लाह के फजल से हो गए। इफ इट हैपेंस, अचीवमेंट के लिए हमने 2 रखा था, पेशेंट सेटिस्फैक्शन, हेल्थ सिस्टम हमारा बेहतर, मरीज की जो सेहत है वो ठीक होनी चाहिए, एंड द हेल्थ प्रोवाइडर्स, और सरकार को भी अच्छा होना चाहिए, कोई अच्छा ही काम होगा ना। क्या हमें जॉब सिक्योरिटी और पेंशन बेनिफिट्स इसके साथ प्राइवेटाइजेशन के साथ मिल जाएंगे? नहीं मिलेंगे। एजुकेशनल प्रोग्रेशन हो जाएगी, वो कहेंगे जी आप पढ़ पढ़ के हो, आपका मसला है, हमारा क्या मसला है, आर वी गोइंग टू गेट आउट ऑफ इट? नो। सेल्फ रिस्पेक्ट और सेल्फ स्टीम हमें मिल जाएगी। मुलाजिम है किसी सरकार के हटके, मतलब एक बंदे सेठ साहब के हो गए, वो भले डॉक्टर ही क्यों ना हो, वो डॉक्टर ही क्यों ना हो, बट इज अ सेठ, हमारी सेल्फ स्टीम और रिस्पेक्ट वो नहीं होगी। फैमिली केयर मिल जाएगी हमें? बिल्कुल नहीं मिलेगी। एलिमिनेशन एंड डिस्क्रिमिनेशन इन बेसिक राइट्स जो हमारी ह्यूमन राइट्स है मिलेगी? नहीं मिलेगी। एलिमिनेशन कल्चर ऑफ फियर, बुलिंग और ये जो रोजाना हमारे इमरजेंसी और ऑर्डर का हो जाएगा, बिल्कुल नहीं होगा। जब वो मतलब वैसे ही हम मुलाजिम हैं तो प्रमोशन का तो सवाल ही पैदा नहीं होता। पेशेंट की खातिर जो सबसे कहा जाता है कि फॉर पेशेंट हम कुछ करें, अवेलेबिलिटी ऑफ डॉक्टर, यस, जैसे उन्होंने फरमाया पहले की हमने मौजूद करवा दिया, वो भी करवा देंगे। सपोर्टिव स्टाफ, अब एक जब आजिर आएगा उसने तो प्रॉफिट बेस्ड अपना काम कर रहे हैं, तो इतने सारे लोग होंगे? कतई तौर पर नहीं होंगे, हो सकते हैं नहीं हो सकते, लेकिन मैं समझता हूँ कि नहीं होंगे। प्रोविजन ऑफ फ्री डायग्नोसिस सर्विस क्या होंगी? उसने पैसे बचाने, जैसे इंश्योरेंस कंपनीज करती हैं, आजकल हेल्थ कार्ड चल रहा है, और आई एम श्योर कि जो डॉक्टर प्रैक्टिसिंग है दे आर अवेयर ऑफ इट। फ्री मेडिसिन का कोई कॉन्सेप्ट हो सकेगा? नो मेडिसिन। डायग्नोस्टिक प्रोसीजर्स वो हो सकेंगे? फॉरगेट अबाउट इट। हेल्थ सर्विसेज सेटिस्फैक्शन इसके साथ उस मरीज की आएगी जो कि उस बीएचयू के साथ जो कि प्राइवेटाइज हो चुका है, और वहां भी अच्छी टाइलें लगी हुई हैं, सब कुछ अच्छा माहौल है बैठने के लिए। सर्टेनली मेरे नजदीक तो वैसा नहीं होगा। आई थिंक कि आप लोग मतलब आज हमारे सब कुछ आपके हाथ में है, गवर्नमेंट की तरफ से जब पेशेंट पीपल सेटिस्फैक्शन ही नहीं है तो गवर्नमेंट उसको हासिल कर सकेगी नहीं कर सकेगी। हेल्थ प्रोफेशनल सेटिस्फैक्शन जो गवर्नमेंट की है वो मिल सकेगी नहीं मिलेगी। हेल्थ रिस्पॉन्सिबिलिटी शिफ्ट जो है वो भी वहाँ पे हो सकता है, गवर्नमेंट कहेगी जी हमने तो बड़ा अच्छा काम कर दिया, प्राइवेटाइज कर दिया, अल्लाह अल्लाह खैर सब। इनसे मैं अतर साहब ये चीज निकालने के हेल्थ इज अ राइट नॉट अ प्रिविलेज, that one we have to accept. Health delivery system is a responsibility, that is a state responsibility, not a commercial business. ये हमें इस चीज के साथ मैं समझता हूँ we have to be convinced और हमें ये तस्लीम करना चाहिए। और बहुत ही अच्छे से नोट के ऊपर दोस्त हमारे यूके से आए हैं, इस्लामाबाद से यूरोपियन हमारे आए हैं, मतलब पढ़ाने के लिए
दोस्त ही हैं।
is for them enjoy लाहौर वालों का नहीं।
Ballerina कहाँ है लाहौर में?
ये वाला ballerina this is from Moscow.
No,
that is from Moscow. And that is from Moscow villa.
But you're saying enjoy
और छोटा सा मेरा मतलब तारफ तो ये कहते हैं कि नारे शाही मैं ऑर्थोपेडिक सर्जन भी हूँ और मॉस्को के साथ मेरा मोहब्बत का रिश्ता है। Thank you very much.
That was wonderful, Ravi sir. So, ये Bolshoi था कौन सा था?
जी it is.
So अब from Bolshoi to Bangla, तारिक साहब, आपके पास 5 मिनट है rebuttal से।
I think it will immediate revulsion to the whole thing, which is very understandable because of its history over a period of time. इसमें
Second last.
second आगे वो जो table थी ना
पीछे ये
now that table, I think my colleagues from UK will absolutely disagree with that. Particularly just the important part है जैसे patient is the center. The kind of model which we envisage was the UK model, where I have spent last 22 years. A doctor, I think there is a lot of work has been done, and I think Zainab alluded to that before. One person who is greatly respected in UK is the GP, even more than the hospital doctors. Hospital doctors give opinion and they bring it back to the GP to have a discussion. Is it right? Should I follow it? There is a reason behind that. And then that reason it is not just simply privatizing that thing to that. There are going to be lots of other checks and balances. Time is going to be short to actually talk about that. What sort of a checks and balances are there on those GPs who are providing those services? It is not that they are giving a building and off they go. They can do it privately. This is why I think that word privatization is a bit of a misnomer. It's not quite right. This is very much of a controlled privatization, so to speak, because they, as I said, 90% of their income comes from the public sector. It is not they are going to get it from the patients. Patients don't pay anything to the doctor. They get it from the public person. So public has got a right to actually monitor it and manage it. So all these things about availability of supportive staff, they have to really have the supportive staff to be able to deliver those services which they have contracted for. So that is not going to happen. This is what I struggle with it. Because I have to hire it, where I have to really actually exercise my clinical and as well as administrative acumen, that I get the right people for the right job. And it is my responsibility to actually staff it properly. Because that is in the contract. That contract which I have, which is binding me, because my 90% of my income is tied to it. If I don't really fulfill that contract, I am going to bust, basically. I am going to lose the business. Provision of diagnostic services, again there is a way there that those diagnostic services are actually provided by the central laboratories, which are actually government laboratories. We have got access to that. So that is not a problem. We can actually order the diagnostic facilities. So they have, I can do MRIs, I can do X-rays, I can do anything, which is paid by in the secondary care, but I have got controls over it as well, that I can't really just order the test. There is a way of doing that. This is why I was saying really that you have to really go through those clinical guidance and then the protocols, and if you are not following them, then you can be held responsible. Now, what was the provision of free medicine? Now, again, that is something which will have to be really negotiated, because that is not doctor's responsibility, obviously. Doctor is providing a prescription, but that is how you are going to kind of organize there. The medications are subsidized heavily. You are paying basically for prescription charges, but I'm not saying that that exact system is going to be valid here. That can be, but it can be modified. There are ways of going around it. Diagnostic procedural hassles, again, depends on what procedure we're talking about. Phlebotomy and things like that, they are done there, but nurses do that. The major procedures, they are done in the secondary care. Primary care is doing a lot more, because we can do that more cost effectively. So that is why we are doing it, a lot more and more of them in primary care. But we organize for that, and there is a provision for that. So that is not going to be valid. Health service satisfaction, what are you talking about? I mean, health service satisfaction, I have to really do that every year. Patient satisfaction surveys, and if I can, I can actually share it with you. My patient satisfaction survey is either excellent or good. There is nothing other than that. And then that is what it is. And then that is not, I'm not just telling you, it is there in my credits. Anyway, I think that is, you mentioned about patients. Patients, I think I'm trying to cover that. Okay, thanks.
Thank you. So I think what Tarika said is that pay anything. They get treatment for free. The government pays to the doctor to treat the patient, and the doctor is a private provider. So that was the point that Tariq was making. Now, Nizami sir, your turn, 5 minutes.
आपकी बात के बाद हम गोगलुओं का मुआवजा जो है मतलब इसके साथ कर रहे हैं एप्पल्स के साथ. So I think we were talking about the BHUs of Pakistan. कि पाकिस्तान के BHUs और पाकिस्तान का हेल्थ सिस्टम को क्या और कैसे करेगा. लेकिन हेंस मैंने सिर्फ 3 उसके लिए बच्चों जो जरा लगाओगे इसके साथ एक जरा मैं जस्ट 3 डॉक्यूमेंट्री तो थोड़ी सी चीजें. ये तो मैंने ऐसी जो हम रोजाना ही करते हैं, टू बी वेरी फ्रैंक, उसी को कंपोज किया था. एक मैं डॉक्टर्स और पेशेंट्स वाली टाइम की वजह से ना पढ़ सका, जो मैंने बाकायदा तौर पे एज अ जर्नलिस्ट जाके लोगों से बातें की, और ये वाली चीज मुझे बड़ी लगा. देखिए इंटरेस्टिंगली मैं थोड़ा सा, क्योंकि हम ब्रिटेन के साथ ही थे, तो मैंने थोड़ा बहुत NHS को भी देखा, बिकॉज वी ड्रीम फॉर दैट NHS मतलब UK. तो उसमें से ये रूल्स की तो मैंने आपके साथ बचा दो. I have shared Russia, but all went over there. एक अच्छा सिस्टम था, एक बेहतर था, जहाँ पे education was free, health was free, people were being taken care like anything whatsoever it was. और सबके साथ ये था कि वो equal सबको मिलती थी. ऐसा नहीं था हो सकता कि जो आपके private या privilege या आपके लंदन की तरह जो private के साथ के कोई बंदा ले लेगा. There was no privilege. So it was Russia. लेकिन उसका सारा कुछ ही वो सत्यानाश हो गया. I have talked about. लेकिन हमें चूंकि अभी सर ने डाल दिया उसके लिए, रशिया की वो हिस्ट्री है 2009 में क्या क्या हुआ और कैसे टूटता फूटता गया और कहाँ पे वो आके आई हैव टॉक्ड अबाउट इट. लेकिन इसके लिए हम नहीं करेंगे, हम NHS पे रहेंगे. ये NHS का एक पेपर है, और इसमें जो लास्ट लाइन इंटरेस्टिंगली, चूंकि हमने 3-4 मिनट के अंदर ये करनी, और मैं तंगीद बांध के मतलब देखो ना, वो कभी भी वो लैला मजनू की कहानी, मतलब मेरे टीचर्स जो बैठे हैं सारे जानते हैं कि मतलब 30-40 मिनट में वो मोड अप करने के अंदर लग जाते हैं, और फिर जाके हम काम की बात की तरफ आते हैं. तो मेरा भी कुछ ऐसा ही सिलसिला है. दैट इज द सेम NHS ये डॉक्यूमेंट है. ये लास्ट लाइन जो कहती है दैट देयर शुड बी अ जुडिशियल रिव्यू ऑफ द सेम एज शी वाज वन ऑफ 375 मतलब जो 1000 है वहां पे इंग्लैंड के अंदर जो हुआ है. ये जो बात कर रहे हैं कि जीपीस को ही फरोख्त कर देना चाहिए, दिस इज नॉट मी, दिस इज द UK बट से. और ब्रिटिश मेडिकल एसोसिएशन जो कहती है, समरी के साथ उनका एक डॉक्यूमेंट है वो पूरे का पूरा, उनके अंदर जाके ये कहती है कि इसके साथ जो उन्होंने मतलब ये रेड वाला मैंने किया क्योंकि अगेन आई वाज अवेयर ऑफ ये टाइप का हमारा इशू होगा पेशेंट केयर एंड सेफ्टी एट रिस्क इस सारे मतलब प्राइवेटाइजेशन के बाद ये बीएमए कह रही है ब्रिटिश मेडिकल एसोसिएशन नीड इंक्रीज एनएचएस रिसोर्सेज नॉट रॉबिंग पीटर टू पे फॉल मतलब इसका मुझे नहीं तर्जुमा आता जो मुझे तर्जुमा पंजाबी क्या था वो मतलब पब्लिकली कहा नहीं जा सकता Supporting doctors under severe pressure within inadequate workforce numbers. ये ब्रिटिश मेडिकल एसोसिएशन सारा असूली तौर पे तो हमें सारे पढ़ने चाहिए लेकिन हैंस हमारे पास टाइम लिमिट्स है तो मैंने वो करने की खातिर मैं रिस्पेक्टेड सर कि we speak about our country पाकिस्तान और दूसरा मेरा नहीं बैठे हैं will bear me out I'm the one who believes कि हमारे यहाँ फंड्स का इशू नहीं है but we have the issue that is the attitude and behavior attitude and behavior at all levels as a patient as a doctor as a teacher and everything that is the main issue जो कि हमारे साथ यहाँ पे मौजूद है और बिल्कुल दुरुस्त का नहीं कि that is one is the issue of the referral system जिसको चाहिए वहां पे आ जाएगा सारे के सारे मतलब तूफान बदतमीजी लगा हुआ है मुझे मेज से वहां से उठानी है तो अगर अल्लाह ताला ने मुझे बहुत इज्जत दे दी गलती से तो मैंने बैल बजाय कहना गिलास से उठा दिस इज व्हाट वी आर और समझते हैं कि जी ऐसे होना चाहिए मैं एक चीज शेयर मतलब आपसे करूं कि मैं आई वाज जनरल सेक्रेटरी फॉर पाकिस्तान मेडिकल एसोसिएशन और ब्रिटेन चले गए और मैं भी इसी तरह से इन्फ्लुएंस था कि वहां तो सब चीजें अच्छी होती हैं मैंने एक मतलब लीड्स वाले को भेजा मैनचेस्टर सिटी के जी मैं पाकिस्तान से आया तो मुलाकात कर He was kind enough जो वहाँ का रीजनल चीफ थे उन्होंने बुला लिया हम टाइम पे चले गए टाइम पे गए तो मैं तो ये सोच रहा था कि हम छोटे मोटे गरीबे लोग मतलब कोई ना कोई सर वो बेचारा पहले तो उसको समझ नहीं क्या वो उठा उसने कॉफी का कप बनाया बड़ी मेहरबानी से मुझे कॉफी आई वाज एक्सपेक्टिंग कि कोई ना कोई बंदा तो आएगा सो दिस इज व्हाट हाउ द वर्ल्ड हैज चेंज्ड और उसके साथ जिसके ऊपर हमें गोरे बादशाह ने लगा दिया हमारे लिए क्या है कि बड़ा बड़ा घर होगा दरबान खड़ा होगा सो हम जिसके अंदर से परवरिश पाई है गौर साहब हमने परवरिश यहाँ पे वो पाई है जो कि गोरा बादशाह हमें दे गया उस गुलामाना सेहत के साथ the system what we are over here and the system which is in UK something or America or so on even the Russia and Cuba कहीं भी हो सकता है we are not far behind we have to think of only the two things which I believe that is the attitude and behavior. That is the main thing. And this is a basic मेरी ये मतलब भले वहाँ की बोले पार्टी ने कहा हो या किसी सोशलिस्ट पार्टी ने कहा हो या इस्लाम ने कहा हो या खुदा ने कहा हो लेकिन मुझे एक इंसान होने के नाते और एक सोशल वर्कर होने के नाते मेरा ये बिलीव है कि हेल्थ इज अ राइट नॉट अ प्रिविलेज और हर शख्स को प्राइवेटाइजेशन ये उसके अंदर हदफ को क्रिएट कर सकते हैं उसको प्रोवाइड थैंक यू
आपने आर्गुमेंट सुनी कि प्राइवेटाइज होना चाहिए इस तरीके से कि जीपी प्रोवाइड करें और हुकूमत पैसे दे और मरीज पे ना करें और जबकि दिलारी साहब का ख्याल है कि ये गोरा बादशाह की गुलामी होगी जो कि हमने इस काम पर लगा दिया और खुद भी वो उस स्टैंडर्ड को अचीव नहीं कर पा रहे जिन्होंने अपने लिए मुकर्रर किया तो वोटिंग आप ये बताइए कि BHUs प्राइवेटाइज होना चाहिए या नहीं होना चाहिए जो लोग इसकी फेवर में प्राइवेटाइज होना चाहिए वो हाथ खड़ा करें तो और वो लोग जो समझते हैं कि BHUs प्राइवेटाइज नहीं होना चाहिए वो हाथ खड़ा करें so therefore the motion is rejected and Nizami Sahab wins the debate one UK 1, Nizami Sahab 2. So, thank you very much. Now we have the next session and you can make your way to the auditorium starting at 11:40. That will be COVID question time. Starting